and quality. This is what we learn in public health school. We fundamentally know that this exists. But in India, we have access. There are private and public hospitals. In India, we know that the government provides a level of care, as well as the private sector is affordable by the middle class. What we are truly lacking in India is quality. And so what we are going to discuss today is going to be how we go from our thoughts of this vision, mission to journey of quality improvement in India, the cost, access, and quality journey, and then learn lessons from what we have been doing in tuberculosis, what corporate India has done as well with K. Dinesh, co-founder of Infosys, who'll be with us, also lessons from Apollo Hospital with Dilip Matai, and certainly from several wonderful speakers from the government, Dr. Rana and Dr. Meena, and looking forward of where we go to India. So let me share with you a case in point, what CETI, the NGO that I and Salil Bhargav have been co-founder for, what we have been piloting, sort of test tubing, and it is the following: taking on one of the greatest challenges that India has, the 27% global burden of tuberculosis. And what we know one clearly in this area of tuberculosis, which is true for healthcare broader as well, is that quality is lacking. To give you an example of the studies done, what they found was 50% of the people did not have the providers did not have the correct knowledge, that 25% of physicians ordered the wrong, did not order a sputum when some patients came with chest symptoms, and 30% did not give the correct regimen. Both in the public and the private sector, quality was lacking. Poor quality care was even based on a gold standard of having a standardized patient come in. What we found was that only 52% correctly managed. There was a big know and do gap. What I am saying the following: if we correct this know and do gap, the knowledge that our providers have, get them to do that the right thing, guess what? We would have made a phenomenal difference in the quality of care. Well, how do we do this? First and foremost, we need to be going from an idea of quality assurance to quality improvement. This is a fundamental shift. Quality assurance is taking away the bad apples, worst quality. Yes, we need to do that. We take action in doing that. However, the idea of quality improvement is we want to move everyone towards better quality. Just imagine how much leverage and improvement we get for the entire healthcare system. And there is plenty of room for improvement for all of us. So what quality improvement is saying, hey, everyone, let us move towards better. And there's a fundamental difference. Quality improvement is system focused. It looks at teamwork. It looks at peer reviewed is valued. Error is an opportunity for learning. So what my premise is that we can improve healthcare significantly and we can use quality improvement. But what is quality improvement? We did a recent paper on this in regards to tuberculosis, and it is an innovative tool which expedites improvement in healthcare. It is a tool that has been used by Infosys, Toyota, many other companies, and likewise, the government of India is also using quality improvement. We need to augment it. We need to be a catalyst for this change. When you look at quality improvement and we bring it down to the practical, that was the theoretical level. When we bring it down to the practical level, what we see is it's a plan, do, steady, act. We'll be seeing a lot of this later today. Fundamentally, what we will be seeing is how quality improvement comes into practice. And quality improvement is also personal. A decade ago plus, I wrote a piece in the Annals of Internal Medicine on how PDSA rejuvenated a marriage. It's a great read. Even if your marriage is going wonderful, I think it is a fun and enjoyable read. So how does quality improvement change us, and what has been done in the literature for this? What we're seeing is that there are programs across the world that are taking on quality improvement as a way of doing things better and differently. This is examples from South Africa and from global lessons as well in TB. In India as well, this is an article from Health Affairs, which talks about priorities and roads ahead, and as well from Frontiers in Public Health. So delivering high quality is the next major agenda. And we have been working on this, as I said, with a project you will hear more about. It's a program directors or DTO's executive course in collaboration. And thank you for USAID and Union for being partners, and certainly the government of India. And so I finish with the following thought. What our mission is very clear, which is the mission I had talked about that all my life I have been working on, making healthcare better in India without more money or time. What is our vision? Use quality improvement principles to do this. What will be our journey? What will be our strategy? Going from quality assurance to quality improvement, building a culture of quality. We're going to need tools that you will see today, the Plan, Do, Steady, Act cycle tool. We will need to train individuals to do this. We need to show a workable model. Then we have to sustain that model. And then we have to scale up that model. So with that, I want to thank everyone for being here, and certainly the colleagues and friends and with our organization, CETI, which is a catalyst for empowering and aligning individuals. It is taking best practices and scaling them up. We are based in my hometown of Indore, and certainly delighted to have you with us. So Commodore Rahman, that as a start, it is wonderful to be here and to share and to be with so many good friends and colleagues and so knowledgeable.
Thank you. Thank you so much, Dr. Manoj. Am I audible?
Yes, you are.
Great, great. So I would now, take a leave from where Dr. Manoj has left. He mentioned no cost, but yet we can improve. So everything that we're going to talk about today, I would like to highlight and emphasize this thing, that it will not bring any more additional cost to improve the quality. Because if the problem lies elsewhere, if the problem lies in the coffers of the government of India, then we're not doing our job. So kindly keep this in mind, and we will talk of the PDSA. But before that, I would like to talk about AAPI, our partner. There is a parallel AAPI summit going on in Hyderabad right now, the 15th Global Health Summit. Actually, we were supposed to do this in Hyderabad along with them, but COVID has played bad boy once again, or a girl, I don't know COVID's gender. But COVID has also given us this great gift of connecting virtually. So you have the write-up on Dr. Anupama right now in front of you on your screens, and may I request Dr. Manoj to say a few words about Dr. Anupama.
Absolutely. Commodore Rahman, thank you so much. And it is my pleasure to welcome Dr. Anupama Gautamukala. She is the president of American Association of Physicians of Indian Origin. It is her vision and leadership to bring many of these forums to place. She is a thoughtful leader and the fourth woman elected president of this ethnic physician medical organization. She is an anesthesiologist in Florida, and we are delighted to have her with us from Hyderabad. Also, Dr. Ravi Kohli, who is president-elect of AAPI. He is a psychiatrist and also qualified in addiction and forensic generic psychiatry, and he's a professor at University of Pittsburgh and West Virginia University. So Dr. Kohli and Dr. Anupama, so delighted to have you, and would be love to have some words from you on behalf of AAPI.
Good morning and good evening. I'm Dr. Ravi Kohli. I hope you all can hear.
Yes, we can. Thank you so much.
I think Anupama might be trying to join right now. She's finishing one assignment back downstairs in the Constellation meeting hall, giving away prizes to the research and poster presentation medical students. And she just posted whether she is visible or not. but
Sure.
is catching
I'll work on getting her in, Ravi.
She was visible a moment ago, but I think she is not again. So may I request Dr. Kohli to please go ahead right now?
Right. Thank you again, Dr. Manoj Jain, my good friend, and Dr. Commodore Rahman Arora for conducting this event again. And I had the privilege and the fortune to join them a few times and learned a lot each time. And like Dr. Commodore Rahman said, we're in Hyderabad. We have about 50 US delegates here, physicians, weathering the bad weather as well as the COVID pandemic, made it here. And we're all doing well, thank you. And we're all at Avasa Hotel in Hyderabad. Beautiful weather outside and great food. We're enjoying it. But we're here for a cause and a mission, which is to improve healthcare and medical education in India. And we just finished a medical education panel discussion. Right now, another panel discussion is going on palliative care. And we have other other programs going on next few days. And whenever I attended these programs, it was really very eye-opening. The quality of discussion, the quality of participation was amazing. And Dr. Manoj Jain is a hard act to follow. He really set the agenda and the bar high, and he really passes it every time and goes further and further. So he has given some great training modules to all of you, and I bet you have gained from it, and you have become experts in the language of quality improvement, and as well as the practice of quality improvement. And we are here to cheer you and applaud you for all the good work you're doing with the limited resources and sometimes a lack of support in preventive care and primary care and tertiary care levels. So here we want to continue this partnership going forward. When my term comes in July and onwards, I'm continuing to plan to work with Dr. Jain and Mr. Commodore Arora and your team to participate. And due to time constraints, I may not have be able to participate all the time. I hope to participate. And Dr. Anupama hopefully can join.
She's there. She's there. I have pinned her. Yes, she's been there for about 2 minutes. She's been listening to you.
Okay.
Welcome, Dr. Anupama. Dr. Manoj, I just want to inform you also that she's there. Yeah.
Great.
Okay, great.
I won't take too much time then. I'll let her say her piece of what information she wants to share on behalf of AAPI and AAPI leadership and the activities that we are doing here. Thank you. Welcome, Anupama.
Thank you, Dr. Ravi. Anupa, glad to have you.
Thank you, Ravi, and thank you, Dr. Manoj Jain and Commodore Rahman Arora and the entire group of, team of people actually who are working on this eradication program for TB. TB is very high in India, and our goal is to eradicate it.
I think
it's going strong, and every year I hear about this project. So AAPI, this year, being the president of AAPI, I had a
Okay, I think we are having difficulty hearing
network issues. Yeah.
Yes. So, Dr. Ravi, I think we will have to, satisfy ourselves with what you said and probably hear Dr. Anupama later. And now it is time for me to, invite and welcome Dr. Rebecca Martin amongst us. And, Emory Global Health Institute is also our partner now. And, thanks for sponsoring the show. Dr. Manoj, may I request you, because you are more connected
Absolutely.
there? Yes.
Absolutely. So it is my deep pleasure to invite Rebecca Martin to share her thoughts on our forum. Dr. Martin is the Vice President of Global Health and the Director of the Emory Global Health Institute at Emory University, which is a sponsor for our program. She has a 22-year-long career at the Centers for Disease Control and Prevention. She has received her doctorate degree from Johns Hopkins School of Public Health and International Health, as with a focus in infectious disease epidemiology. Rebecca, it's a delight to have you here, and thank you so much for being a great promoter. I still remember the conversation we had about this forum, and you were 100% in support of this, which is incredible, even after a brief discussion. So thank you so much.
Thank you so much, Dr. Manoj Jain, and thank you, Commodore Rahman, as well. It's an honor to be here with you today, to be part of this with AAPI and CETI, and to welcome all the participants as well. The Emory Global Health Institute at Emory University believes in the importance of the implementation and quality improvement processes that can increase coverage and reach more people while decreasing the missed opportunities and reducing barriers to achieve the ambitious but achievable goal for TB in India and other important global health goals. As Dr. Jain mentioned, we had an initial discussion, and I was very much excited about this because after my career of working with and supporting and collaborating with many countries, as he has said so passionately and with so much knowledge, the importance of quality in the work that we do that does not take additional funds or times. We recognize the importance of having effective tools and how then to use those tools to have effective programs to deliver the work that is needed to be done. And this requires the continuous review of the performance through the ongoing efforts that we've talked about, the quality improvement, with continual feedback, motivation, the exchange of information, which you're doing here today and learning from one another, as well as the evaluation of the programs and bringing the science into the work that needs to be done. Personally, I've had experience working with quality improvement in immunization, working with vaccine providers to increase coverage in their catchment areas. And I did collaborate with the government of India and partners as it achieved the incredible goal of eliminating polio from India. This took much work in looking at the quality improvement and the continual effort to use data in real time. This has also been done in my work in working globally in HIV and TB and learning the importance of using information in real time to make changes, that continuous quality improvement, so that we can improve programs and to identify the scientific research that's needed to continue the programs forward. At Emory University, the Emory Global Health Institute serves as a platform for a multidisciplinary approach to define and develop global health solutions. Our work in child health and mortality prevention surveillance and working with national public health institutes around the world showed the importance of the continuous quality improvement that's needed once you have information, how that's used in real time to improve and to continually review the systems that are delivering programs. Working with colleagues across the Emory University, we're embarking on developing global health leadership training programs for defining cadres in global health, environmental health, discussions about expanding our collaborations with the TB Center at Emory University and future global health leaders, how we can continue this work. And an important foundation is having the communities of practice, such as the objectives that you are here today for this session and into the daily practices to improve the quality of the programs, identify the gaps and shore them up. I look forward to hearing and learning from your experiences today during this session, learning about the new tools and being part of the discussion. I wish you all a successful session as part of the 15th Annual Global Health Summit. And it's an honor to be here with you today. Thank you so much.
Thank you, Rebecca. Great to have you. So, Commodore Rahman.
Yes, thank you, Rebecca. I'm sure we will not disappoint you, and there are going to be wonderful learnings which are going to happen today. So, Dr. Manoj, I have put myself on the screen.
Sure, perfect. So next, we are going to now get into the details of how this really happens. And to show us that is going to be Commodore Rahman. And just to give a little bit of a background, Commodore Rahman has taken voluntary retirement from the Indian Navy. He is a phenomenal individual who has 30 years of experience in leadership, project management, business strategy, financial and operations management, corporate affairs, as well as working and making our program for tuberculosis successful in training the district TB officers. He has officially represented the government of India in more than 15 countries, as well in the United Nations. There are so many things I can talk about Commodore Rahman. I think you see him and his thought process and ideas come to life in our session here. So with that, Commodore Rahman, I would invite you and Ms. Pratibha, Dr. Pratibha Kohli as well to share how we have moved forward and brought some of these ideas to the floor.
Thank you, Dr. Manoj. At one point in time, I was thinking if you had somebody else's resume in front of you, or you were talking about me. Thank you so much for such kind words. And the best part is that we are maintaining the time, and I will also make sure that I say my piece in exactly the time of 5 minutes allocated to me. Thereafter, I will hand over to Dr. Pratibha Kohli, and we will come thereafter to Dr. Chandresh Vyas. So Dr. Manoj shared with us his vision of quality, of reaching quality, the third leg of the stool, which is missing in our healthcare. We have the excess, we have everything else, but the quality is missing. So we realized that, we need to do something about it. So we devised a curriculum. We studied the problem, and we realized that we need to bring in quality in process, quality in our policies, quality in our implementation and execution of the program. Because gone are the days when the political will was lacking. So the political will is there, and we chose the TB program because it came to us through I Defeat TB project under the grant of USAID. A wonderful opportunity came our way to prove and make our point known to everybody else. So we took over this program manager's executive course under the I Defeat project, grant of USAID, and being implemented by the union. And I'm thankful for the representatives of both the organizations are here with us today, and they will also share with you their point of view. So we realized that, we cannot be talking of clinical issues only. We have to talk of quality improvement along with leadership and management. The soft skills which are must for the district tuberculosis officer, who was the last mile connectivity with the patient, as also his inputs are available to the government of India at the apex level for decision making. Now, he was part of a larger study that we did. What was that study called? My next subsequent slide will show. So we made a curriculum with team building, with data analysis. We did a big PDSA, Plan, Do, Study, Act, to understand and realize where the problem was. What was the root cause? Where we should hit? What should be our focus? Where should we aim at? And we realized that this was the man called the district tuberculosis officer who could actually transform and change the direction of our TB program. So we focused upon him. While we were doing so, and while we were teaching them as per this curriculum, and teaching is a wrong word, when we were knowledge sharing with them, because adult education is the most difficult thing of all. If I start giving Gyan here, Gyan for my all foreign audience is, like seers and preachers in the church give. It's a monologue. You have no option to debate or have a dialogue, but you just gain. So nobody will listen to me. The program is designed differently. So while we were doing this, the DDG, the Deputy Director General of the Central TB Division in the Government of India, came up with a problem to us. And he said that the Government of India has launched a TB Arogya Sathi app, a mobile app, wonderful app, but it was not getting proliferated in the masses amongst the patients. If it could happen, our TB program would get a fillip. We rose to the opportunity and we said, we will take over this problem and showcase to the Government of India, as also to USAID and the Union, what our program could do. And my next subsequent slides will showcase to you that we undertook this program in 3 states, Gujarat, Madhya Pradesh, and Rajasthan. What is in front of you on your slide is the outcome of the TB Arogya Sathi app download. You know, when you start from the first one, if you follow my cursor, the blue bar, that is how we started. This is the 3 states where the program was running, and this is the rest of India. When we started, the 3 states were at 0.47. Rest of India was at 1.79. This is the progress every month we ran the program. When we completed the program in October, 24th September to be precise, and this is all government data. Okay, it is apples to apples and oranges to oranges. We handed over at 13.7% downloads in the states that we were talking, and Indian average was 5.86. To showcase to you how the 3 states performed independently is right now in front of you on your screens. You can see how the state of Madhya Pradesh from 0.15 rose to 19.29. That was a kind of thing. But then we realized that, you know, if we have to showcase what we're doing, we need to see what we did in the states. In the states also, there are districts where we were present and certain districts where we were not present. So the orange bar indicates where we were not present, where we were not running the course. The blue bar indicates where we were running the course. And look at the comparative figure. The TB Arogya Sathi app data figures in where we were present is all in the range of 60s and 70s%, wherein we were not present is all languishing at 30% and below. So the proof of the pudding is in eating. Not only this, the TB notification and all the 14 factors on which the government of India takes decision about the district performance in the TB program, how the WHO takes decision about how the TB program is running. All those factors, they showed improvement depending upon which problem the district tuberculosis officer chose. It was a voluntary program. Look at the attendance, please. We had more than 80% attendance, 75% of the time. Coming to the test we did, we conducted pre-test and post-test. The median rose from 57 to 72. The DTOs who scored less than 33% in the first, before the course began, were 4. We trained 59 DTOs, nil thereafter. The percentage who scored distinction was 4.25%. It rose to 42% approximately after the course. The feedback from the DTOs was taken every month. And batch 2 is going on now, and the DTOs are present amongst us. They will discuss, they will showcase you with you, and they'll talk about it. Have a look at their feedback about the presentations, about the QICs, I'll talk about them, topics, how the knowledge was shared, and if they would recommend the course to everybody else. 4.6 out of 5. All the readings are on the scale of 1 to 5. They said, we recommend this course to everybody else. We started a newsletter. About the newsletter, I'll cover again in the session. Dr. Nadir Lal is there with us, what we did and why we did with the newsletter. I'm sorry.
So,
okay. Yeah, well, I clicked on the, just engage for a moment, Dr. Jain.
yes. So what you see here is a detailed example. You may be wondering, why does it matter in showing this one app and the impact? The reason is because once we see the impact of one app and how it has changed the TB for a patient, what we can do is scale that up. And so, Commodore Rahman, yes, our timeline.
So what is our timeline? You know, Dr. Manoj spoke about the vision and the mission and the journey. Journey is on. Our objective is to get this training program run for the entire country. We have been given the mandate to do that and hand over the program to the Health Ministry after 4 years to be implemented pan-India as a curriculum to be included in the NTEP program, Module 9, which talks about training. So that is our ultimate objective. Now, how do we do this? Here it is. Now I'm marketing. So if somebody is missing it, you should understand. This is who we are. Dr. Manoj Jain and Dr. Salil Bhargav, the co-founders. and the core team. This is our faculty. Few of them will be engaging with you over next 1 hour. Our guest faculty, few of them will be engaging with you in the next 1 hour. We are very happy to have Mr. K. Dinesh amongst us, the co-founder of Infosys. He'll be there talking to you. And we achieve it through our quality improvement counselors. This is my team, which I am proud of. These are the interactive people between us and the DTOs. So with this, I hand over to Dr. Pratibha Kohli. She is the one who is the faculty for PDSA, a medical microbiologist, and she has decades of experience in hospital operations, quality and administration. She's a certified NABH auditor. She is the one who talks and showcases what we have been professing about. We will now talk of how the PDSA was conceptualized and then end it with the DTO who will showcase it to you what he learned. Over to you, Dr. Pratibha.
Thank you, Commodore Rahman. I hope I'm audible.
Yes, you are.
Thank you. So like you said that we have taken help from QIC. So how we actually started with PDSA, you know, the PDSA is a scientific method and it is absolutely action-oriented learning. So we engaged our QICs. We asked our QICs to help our DTOs to teach this PDSA cycle one-on-one. So how we did it, we break down the PDSA into small parts. We plan, do, study, act, as it is stated by Dr. Manoj, that we have adopted the Toyota system. So plan, do, study, act. In plan, we define our objectives. We asked our DTOs that what, who, where, and when, what you want to improve, what are the objectives, what you want to carry out. And in do, we ask them to understand the processes they want to improve. We ask them to do the measures, right? And after doing that, we did study, we measured, we did the process measures, we did the root cause analysis. And also after this, we did the run charts and we analyze and study the findings accordingly. What worked and what didn't work, we got into the act and we abandoned. Then we opted for the next cycle, whether to abandon, whether to adopt, whether to adapt. If it is not working, we abandon the cycle. If it is working, we adapt the cycle. And if we need to, if we have to tweak something, adaptation is there. If we have to accept the cycle as it is, we adopt it. Then next slide, please. Then you can see the chart here, how we improve it. We don't take it as a rock. We take it like small stones. We go it in a small fashion. We break down the aim into smaller one, like in small, like if we are visioning like it's 5 years, then we take it very small, 3 months. So in 3 month cycle, we do the PDSA and we gradually, continuously improving step by step, and we achieve the biggest target. So this is what we call quality improvement, which closes the gap slowly but steadily. Next slide, please. So how we designed the QI project with our DTOs, we ensured that it should be a very short term but measurable part. We did not go with the perception. We absolutely went with our objectivity. So our aim was incremental changes. We ensured that it should be in control of our QI team. It should not be controlled by the external factors. We ensured that our QIC one-on-one stayed with the DTOs. We had a brainstorming meetings with them and devised our aim statement. And then we ensured also that they are not getting controlled by external or other source team. Like we say that finance part is something which is not controlled by any DTO. We did not go to that segment. Next slide, please. So step for QI project, how we designed it. So we identified and prioritized the problem. We listened to the DTOs. we jot down the points where they are facing the problem, and then we identified with their own team, then develop aim statement and objectives. After with the consensus of the team, we developed that. We have a tool for the aim statement. We collected and analyzed the baseline measures. We also have a tool for this. You will witness that tool. We called it CETI model of PDSA. Identify, measure, and indicator that will measure improvement, and devise data collection plan. We collected the data, we analyze it, whether it is going in a positive trend or in a negative trend. If it is going in a positive trend, we are adopting the cycle. If it is going in a negative trend, we are abandoning the cycle. After that, we did the problem analysis. We did fishbone analysis for that. Then we did the process mapping. After that, we did plan for change, intervention, brainstorming again, whether our planning is going as per the desired thing or not, as per our aim or not. Then we implemented the intervention there and provided the feedback to the team, because we wanted to see the improvement. In every aim statement, we took some measures that we have to increase 5% or 3% or 10%. So we always check whether we are improving or not in that direction. After that, we disseminate the results and integrate the new standardization of process and practice. This is the step for designing a QI project. And we will hear it live from our DTO now, how we did it, how we devised it. Over to you, Ramanji.
Thank you. Thank you so much. And may I request Edwin to put the spotlight on Dr. Chandresh and get him in the panelist. I would just in the meantime highlight that whatever Dr. Pratibha has said, our objective was that we should not increase the work for our DTOs. So the USP of our program is PDSA is an old science. We modified it and evolved something which is our own, and we call it ePDSA. The tool was modified digitally so that the way the poorest and the most remote district, where the DTO was still working with a pen, paper, and register, he should be able to put that data into the Excel sheet, and everything should populate for him automatically. He has to only think about the problem and start acting the way he should, and the solutions emerge automatically. May I request Dr. Sadaf, QI Sadaf, to start sharing her screen and start the PDSA. If Dr. Vyas is not able to come in, she should explain.
Sir,
and in the
here
meantime,
with us.
yeah, he's there. Okay.
Yeah.
But before that,
Yes,
I would like to invite Dr. Manoj. I think he has something in mind to share.
Absolutely. So what we're hearing here from Commodore Rahman and Dr. Pratibha Kohli is the details of how and what was happening to make this. Now, again, we are showing this as an example, as an idea that needs to be scaled up, not in TB alone, but in the entire healthcare system of India. And we believe that it can be done. Now, let us hear from Dr. Chandresh, who's on the ground doing this. And so Dr. Chandresh, we'd love to hear what your experience has been in using the PDSA cycle.
Sir, good evening, everybody. During my sessions of PDSA cycle, I just joined the public as a district TB officer, as a newly in a district of Junagadh. We identified our as a low public notification. During I talked with my and shared with the team. I identified that public notification is lower one. So we have just put on us as a target being we have to 10. Four things said. One, good quality active surveillance is going on. Then contact tracing of each and every TB patient of current on treatment as well as the past 3 years. Then suspect referral from the healthcare worker, especially from the newly appointed of the community health officers, as well as there is a one stream is going on. ASHA is every Saturday, there is every PHI, there is a meeting for that. So whatever the patient that might be lapses from our system. So on a week basis during surveillance, ASA catch up and sputum transportation, we are doing so. So during our PDSA cycle, we in our third quarter, we achieved it very nicely. Our team has worked at that very fine, and we strictly follow our PDSA cycle. Especially PDSA cycle helpful me and make a public health officer to medical manager. There is a PDSA cycle which is very beneficial for the officer, for the improvement of their skill as a managerial, as a computer, and everything we achieved during our PDSA cycle.
Thank you, Dr. Chandresh. And if any of the panelists or anybody may like to ask anything from the DTO, we have 3 more DTOs, in fact, Dr. Chandresh included, who will be there in the open forum discussion at the end of this forum to share with you all the ideas, their experiences, and their journey, how they found the full process. Yes, Dr. Manoj?
Yes, I was going to ask Dr. Chandresh, this PDSA cycle, did you find it that it could be used for other topics and expanded to help your work further?
Yes, sir, definitely. Especially it works and helpful to me as a team building, because as a manager, we are all working as a team manager. We are serving for the population of 15 lakh. So direct under there is a 30 people's team is there. So how to enrich my second line, how to upgrade their knowledge, their skill is like as me. So we did it and we done it, sir.
Okay. And did it cost you any more money to do this, or any extra significant time?
No, sir. Actually, on this is a very weekly basis. So only every week I'm eager to attend this meeting because it's improved me a lot by my knowledge, my skill, and my attitude, sir.
Thank you so much. So I think what you're seeing and what we're seeing from the ground and we're hearing is that we can significantly improve healthcare without more money and without more time and with the proper training. So with that, Commodore Rahman, let us go to now a picture from the national level. So if you would introduce Dr. Girder Gyani, who's a close friend, and he's has done wonderful work at the national level.
Thank you, Dr. Manoj, and thank you, Dr. Pratibha and Dr. Vyas. Dr. Girder Gyani, I don't know if he would need an introduction, but I have to introduce him as the founder of Healthcare for Quality in India. I have to call him as the Quality Man of India. He was the Secretary General of the Quality Council of India from 2003 to 2012, and he was the main pivotal player in formulation and operation of the NABH, National Accreditation Board for Hospitals and Healthcare Providers. So I would not stand between my audience and Dr. Gyani. Dr. Gyani, we welcome you to the forum, and we want to hear from you because your thoughts are all wisdom for us. So I'll stop sharing my screen, and may I request you take over, sir.
Thank you. Let me share my screen and okay. Is it okay, visible?
Yes, visible.
Yeah. Thank you very much, Commodore Rahman, and our very close friend, Dr. Manoj. As the topic is that India's healthcare journey into, India's quality journey, I will say, in the healthcare. So in fact, I will cover journey from inception to 2012, where I, superannuated from my department. Later on, of course, my 2 other colleagues, Dr. Meena and Dr. Rana, are going to speak. In fact, Dr. Rana worked with me when I was actually working in NABH. So let me begin here. Let me show the first slide. Why I want to show the first slide, this one. Dr. Manoj has been the advocate of on quality, and he will agree with me. The quality survives or thrives in competition. You see, you have to be in the consumer's market, what we call consumers-driven market or patient-driven market. If the patient or consumer has got no choice, very limited choice, then, quality will take the back seat. Otherwise, there are, of course, other means of driving the quality. By regulation, we can drive the quality. By payers, we can drive the quality, which actually has been going. But the best part of the quality is that when it is driven by the consumers. Unfortunately, as I say, this slide, why I want to show you, because you can see how much shortage is there of the healthcare resources in our country. 1.5 beds per 1,000 population, as against 3.5 required. 0.70 doctors per 1,000 population against 1.0, 1.5 nurses against 2.5. Now, if these are the parameters, and on top of it, the most of the tertiary care healthcare is available in tier 1 towns, some little bit in tier 2 towns also, of course, but tier 3 and rural areas do not enjoy any tertiary care healthcare setup. This again is like a chicken and egg story, because there are no doctors, so who will set up the hospitals in the tier 3 town. That goes on and on. So my point was simple here, that I am going to talk to you in this backdrop, that in spite of huge shortage of the healthcare infrastructure, we have succeeded to reasonable extent in establishing the healthcare quality framework in our country. So let me begin here. The journey starts actually from 2000 onwards. Till 2000, we were not talking of quality at all, particularly in the healthcare. By the time ISO 9000 was, being talked about in the other sectors of the industry, in fact, 1983, 84, 85, little bit of, QMS started coming in. And so some hospitals started, getting themselves certified to ISO 9000. In the meantime, of course, the laboratory, as usual, took the lead role, and ISO 189 came in a big way in the medical laboratories. By this time, McKinsey presented the report that there is a huge market of medical tourism, and India should get into this field of medical tourism, and it projected $2 billion US dollar market by 2015. Now, by this time, we had some of the, I will say, if not exactly state of art, but really top of the line hospitals coming up in our own country. So obviously, this report was aimed at these hospitals, that they should work on it and try to attract as many as possible, tourists from neighboring countries, Europe countries, even far like the USA. Based on that, our delegation, when they visited United States, the United Kingdom, and later on in the GCC country, everywhere they were asked a simple question: are your hospitals accredited? And this question was then presented in the parliament. And in the parliament in year March 2005, this question was asked by one of the members who was part of the tourism ministry. And obviously they had no answer. And this question was then referred to the Ministry of Health. And Ministry of Health, because I was that time heading Quality Council of India, they referred it to us, that what is this healthcare quality accreditation? To be very frank, they had no idea about it that time, because they thought it is something like ISO 9000. So that is where, the task started. And we accepted the work at Quality Council of India. And it was very fast track mode, I will say. In March, the question was raised. In April, the governing board of Quality Council of India accepted the task. Immediately, they put up the structure like any other international, other global countries, they adopt this one. They immediately establish the accreditation board and other arms or other wings or other organs of this kind of board. And then the real task started. And in June 2005, we got hold of 6 senior doctors from various specialties, including administration, and they were assigned the task to develop this standard. The question I would like to tell people here, some of the audience who may not be aware about it, that unlike medical laboratories, there is one standard, ISO 15189, which is prevalent throughout the globe, world. In hospital case, each country is given option that you develop your own standard, get it approved by International Society for Quality in Healthcare to become the globally acceptable. And that is where we started the task of developing the standard. So if you see here, June 2005 and December 2005, obviously it was a difficult task for us because we had no experience of this kind. Particularly, I'm talking of the doctors. I had the background on the quality, but the doctors obviously were first time getting into this kind of business. But still they did wonderful job. In 6 months time, they produced the standard, which was approved in January 2006. And in February 2006, the standard were launched in the country. And these are some of the examples because this is a history that, the MIMS from the Calicut was the first hospital to apply in 2006. And during this year, we trained 100 assessors, 100 surveyors for undertaking the assessment. The turning point came that in 2007, that means 1 year after we launched the standard, only 5 hospitals could qualify to receive accreditation. So you can understand that even hospitals were not prepared for this kind of task. And the actual pull or push came when these 5 hospitals were handed over certificate of accreditation by none other than the president of the country, Dr. APJ Abdul Kalam. That made huge impact. The hospital started realizing, oh, come on, this is something, which president presented to the hospital. And of course, then there was no stopping. We started getting large number of applications. And another turning point came when Ministry of Health linked the NABH accreditation for the implementation of the very prestigious central government health scheme, which is the scheme which actually under which, all central government employees, member of parliament, Supreme Court judges, High Court judges, all are extended the free healthcare services. So the government decided that whichever hospital has got accreditation to NABH, they will be given 15% additional reimbursement. So that is where actually the real push came. And of course, then we went on developing more and more standard. And the standard which was launched in 2006 was submitted to ISQA, and ISQA accredited our standard for 4 years. First, that is the second edition, 2008 to 12. We did something more here, unlike other countries. We engaged with the state government and we tried to impress upon them that so far all applications are coming from the private hospitals. Why don't the public hospitals also come into this game? And so the state like Gujarat was the first state, Madhya Pradesh, Kerala, Tamil Nadu, they signed the MOU with the Quality Council of India. And the first government hospitals got accreditation, which was the Chacha Nehru Bal Chikitsalaya in Delhi, pediatric hospital. So this is the way, we started working on it. And then in 2009 and 10, the Ayush ministry came and they came forward that even they want to get into the accreditation process. And we developed the standard for them because their standard obviously were different. And similarly, we signed further MOU with other states like Andhra Pradesh, like Assam, and the blood bank started getting accreditation. Dr. Rana, who is here going to speak, was in charge of this blood bank program. And then, of course, this journey continued and continued. We went into launching of the medical imaging accreditation, dental hospital accreditation, clinics accreditation. And on top of it, in 2011, Philippines became the first overseas country which adopted the NABH standard. And we launched the NABHI, just like Joint Commission International, we launched NABHI. And hospitals from the Philippines started applying to us. Further, if you see, I'm trying to show you the journey year by year, 2010 and 11, more states like Karnataka, Jammu and Kashmir, NDMC from Delhi, and then the ECHS, which is the labor-oriented insurance scheme, they also signed MOU with the NABH, giving recognition and giving incentive to the hospital which are impaneled with the ECHS to getting more reimbursement. After that, another hallmark point came in the country where the Clinical Establishment Act, which is a regulatory standard, that task was given to Quality Council of India and NABH. That as an accreditation body, we were given the task to develop the regulatory standard. And so anyway, so these things went on. And if you now see 2006, we launched, and by 2010, we got 100 hospitals accredited. So, journey like let us say 4.5 years, 100 hospitals got accredited. If you remember, in 1 year, only 5 hospitals got accredited, but remaining 4 years, we got 100 more hospitals accredited. So this is the way the push came. Now, 11 and 12, this time the 3rd edition of the standard also got accredited, because every 4 years we have to reapply for accreditation. And this reapplication doesn't mean same standard. We will have to improve. This topic today, the topic is on the continuous quality improvement. So we will have to show to the SQA that based on the feedback from assessor, based on the feedback from the hospital, from the stakeholder, these were the changes were made in the standard, and then they were submitted to the SQA, and we got the accreditation from the SQA, this one. Other program, as I just now mentioned, blood bank, Ayush, wellness center, dental center, these accreditation programs were launched by the time of 2011. This is a certificate which is normally given by the SQA when you get the standard accredited. And this is another certificate which is given when the organization is also accredited. So this is the first time, of course, our organization also got accredited. Till now, we were only having standard accredited. Now the organization also got accredited. So this is a photo which you can see the team of 3 SQA assessors in the center. And on the left of the screen is Dr. Narottam Puri, who was the chairman of the accreditation board. On right, my photo, then extreme right is Dr. Rana, and our all staffs are here. So this was a landmark, in India's quality journey, because not only standard, but the organization NABH got the global recognition. And the problem which actually we felt till 2012 was that regulatory framework in our country was very poor. Because of that, most of the hospital lagged in the basic infrastructure. And when they were asked to prepare for accreditation, obviously they were unable to do it because they didn't have the basic infrastructure itself. So that is where, if you have good regulatory framework, obviously taking accreditation becomes much easier. 70% of the healthcare services initially, obviously not initially, even today, are from the private sector. And the private sector obviously will go for accreditation only when they see there is a incentive, financial incentive. Because by the time it was difficult for them to understand that accreditation itself will give you the financial benefit. It will improve your bottom line. But they wanted to see the direct benefit, like CGHS had given in the empanelment. But anyway, that culture started changing and people started realizing that, yes, it is in our interest to go for accreditation. So that journey started going on.
You have a minute.
By this time, 2012, when I'm talking, in the 9 years, 300 hospitals got accredited. So I think from any standard, you can say it was a reasonably good progress, particularly in the country where I said the regulatory framework was not up to the mark.
Great, sir. Sir, I hate to interrupt you, sir, but you have a minute to wind up, sir.
Yeah, that's right. Last one now. So this is ultimately we recommended to the government that simultaneously you must improve the regulation. Simultaneously, we must encourage the impanelling agency to, ask for the accreditation standard, and that is what actually is happening. And this is the last time showing this slide, 2012 to 21, which I will expect Dr. Rana and Dr. Meena to cover. But by the time when I'm talking in 21, the 5th edition of the NABH also has got accredited. And many of the state government run healthcare schemes, insurance schemes are relying on NABH. And that is where NABH has launched a diluted version also to encourage hospitals to take quality journey. And that is what we call entry level certification. And last slide is that this is the status today in front of you, that we have got 1,355 hospitals fully accredited. A good landmark now. While 7,000 are those which have got that diluted version certificate, which we call entry level, remaining blood bank, radiology, this is the number. So I think by this time, 21, we have got reasonably good progress, and I can say quality has taken the roots. Clinicians have adopted wholeheartedly the quality journey, and patient safety is showing the marked improvement. Thank you very much.
Wow, amazing, Dr. Gyani. Thank you so much for sharing that journey of quality improvement and quality in India. And I don't think I would be exaggerating if I would say that you were one of the founding fathers of quality improvement in India. And I still remember our meeting in the early 2000 that we were at a hotel in Delhi, and on a whiteboard, we were talking about how NABH standards should be and learning from JACO. And I remember that formative meeting that we had and continued our collaboration. And you so nicely showed how quality improvement in the hospital, inpatient and private sector setting has then now been moved to so many places. And then we saw from the examples earlier with Dr. Vyas, how quality improvement has come into the outpatient public sector setting. So a great sense of journey. Thank you so much, Dr. Gyani, for sharing your thoughts and being with us.
Thank you so much, Dr. Girder. Sorry, Dr. Manoj. It is just that I was itching to say something.
Please go ahead. Please go ahead. Yes, absolutely.
Dr. Girder, thank you so much. I would not go into details because Dr. Manoj has covered, but two things very nice. One is your last slide, which shows that 1,355 hospitals are fully accredited, and 7,000 plus are certified. That's most positive. And second, about that you said all your piece absolutely in time, spot on. To all our attendees, we are following exactly as per the timeline. That is
Dr. Manoj has been great motivator to me personally during his few visits earlier time. He really gave a push to me particularly, and which did help me. I want to thank Dr. Manoj Jain.
Absolutely. What a deep pleasure and collaborative relationship. And Girder, our journey is just on the starting and the early stages. We're teenagers in quality improvement. We've got a long way to go. So great. Now it is my deep pleasure to invite Dr. Ruben Swamikan. Dr. Ruben is the Chief of Infectious Disease Division at USAID in New Delhi. He has worked closely with a wide array of stakeholders, including United Nations organizations, the Government of India with National Health Authority, and multiple areas. The most striking thing and warm thing about Dr. Ruben is his work that he has worked with marginalized and vulnerable populations through access to quality, affordable healthcare in India and globally. He is a close friend, and for a decade now, Ruben, you have been a great proponent of quality and of certainly the healthcare improvement in India. So glad to have you and to be with us today.
Thank you, Manoj, and thank you, Commodore Rahman. and all the speakers. And I think a big thank you to all the participants. So 130 participants have tuned in. So it's extremely wonderful to meet you all at this very grand kind of an event. As Dr. Jain mentioned, I have spent over 2 decades now in TB, and one of the things that we started off with was mainly about reaching out to about 3 million TB patients every year. Okay, and that's been the challenge. So it was all about quantity. The estimates speak of that kind of a number. We've been reaching about 2.4, 2.6 million cases. But the whole premise of the National TB program was to ensure that we are able to reach out to the quantity in terms of numbers of patients. And over the years, everything was focused on the clinical aspects of early diagnosis, treatment, adherence to treatment, completion of treatment. And after that, it was about post-treatment sequelae or any issues that arise. So it was very focused on it being a very clinical-oriented sort of a response to a disease. During the course of the last, let's say, decade or so, we found a number of different things that play a significant role in how the disease evolves and the kind of support that a patient needs. So we then started focusing on various areas of looking at how we can enable the patient who needs to take at least 6 months of treatment get better in the best possible way. So during that intervention, what we really lost sight of was quality. And like was mentioned in the past by the various speakers, you need to look for quality at the last mile. The ability to ensure that the patient, who is the most important person in the project or in the program, receives the best possible quality that's available in the market. And so I think with that in mind, when this particular project came up under the USAID banner, we were very excited to see that the district TB officer, who is invariably a doctor by training, has very little concept or skills in managing a project of the size of his district. He's never been trained on that, and he just uses whatever skills he has learned, which is not uniform across the country and varies from individual to individual. So in addition to his clinical skills, would it be possible to build his managerial skills was what we were looking for. And so I think this particular project, as you've just seen, has shown us some tremendous results. We've seen and we heard from a district TB officer from Junagadh who mentioned how it has actually supported him in being a better program manager, in getting to know how he is able to do the PDSA cycle and use the PDSA cycle over the long term. So what has really happened is that the PDSA cycle is now embedded within the DTOs, and they are using it virtually on a daily basis for everything that they are doing. And I think this is going to be transformative in the coming years. As more DTOs get trained, we will see that the quality of services to the patients improve dramatically. And with that, the quality of outcomes for the patients who are on treatment will also improve dramatically. So, it's an honor to be a part of this, and I am extremely happy to see this being taken to the next level. I would like to thank AAPI and CETI, Emory University, and the Emory Global Health Institute for all their hard work, support, and getting down to the nitty-gritty and converting what has been on paper into action on the ground. And I think lastly, I want to thank all the district TB officers for being so enthusiastic, for taking the time and for willing to learn, even though they are at such a high position within the district. So I wish all every success, and I look forward to more as this project reaches its peak. Thank you.
Great.
Dr. Jain, back to you.
Great. Thank you, Dr. Ruben. So, as you were speaking, what this whole idea came to me, which I had not realized and recognized before, even though I've been working in this for decades on. And it was this: in medical school, you and I, we learned, and we were in this area where we focused only on medicine. And we did what a doctor does. A patient ki take care karna hai, patient ko kaise acha karna hai. That is what we were doing all our lives. And then there's another end, which is you have to do management. You have to take care of 2,000 TB patients in a year, and it's hard. And in essence, what quality improvement is doing is actually bringing those two together. This is in a way a hybrid of your medical knowledge and the processes, the scientific approach, and the management skills of how to handle a team and so forth. And so I really had not realized that before, but the marriage of medicine and management is quality improvement in many ways. So thank you so much for sharing that. So Commodore Rahman, over to you. And as we go to the next conversation on how TB can be a model for healthcare.
Yes, thank you. Thank you, Dr. Ruben. Thank you, Dr. Manoj. And before I call upon the next speaker, he is our faculty, and his profile is right in front of you, ladies and gentlemen. A quick note, one has to realize what is happening in our country right now. We are launching satellites for the entire world. We are launching, aeronautical industry is coming up. We have our own aircraft for the defense called Tejas. We are in the manufacturing industry, in the automobile industry, we are coming up. The mobile industry is shifting to India. The solar industry is coming to India. All this is resting on quality. If this will not happen, no country will be able to do business. So while we are talking of quality in healthcare, parallelly, the similar thing is happening across the globe. So now is the right time to board the bus of quality, and we shouldn't be left behind. So with this, I welcome Dr. Mohan Kohli, trained medical professional with more than 15 years of experience in hospital planning administration, quality improvement, healthcare delivery management, public health management, and strategic planning. I would not come in between you and him and the audience. I welcome you, Dr. Mohan. Please share your presentation and enlighten us.
Thank you, Dr. Manoj and Ramanji. I am going to actually start where Dr. Girder Gyani just left, because he actually made the platform for me. And what I believe is there is no difference between public health and private healthcare. Healthcare is the same, treatment is the same, hospital, the setups and everything is the same. What changes is the management changes, but the principles always remain the same. The source of funding changes. So what we have done over here in our, this course which we're talking about, the quality improvement course for district TB officers, let's take a look at what is currently happening, what's the scenario in public health in India, and what we have done in the TB program over the past 6 to 8 months, how we can actually take it into other programs and the bigger public health scenario. But what we are looking into it, we look into the relationship between health outcomes and quality, why we would require quality improvement in healthcare in India. Some things have already been told. What is the existing structure of the structure and the quality system in the healthcare in India? The linkage between the TB program and the overall healthcare delivery system, and some learnings which we can take from this program to the overall health system. It's already been, we talked about NHM actually coming out with a lot of infrastructure improvement, manpower improvement. it's well said, but it does not lead to improvement of healthcare status of the population. Why? There is an important component of quality which is missing. You add coverage along with quality, you get a better improvement outcome at all levels, right? So just increasing the facilities and manpower leads to access, but improving the quality over there leads to better outcomes. There are studies published, and there are sources over there. Lancet, there is some Global Health Commission which has, come out with certain things. In low and middle income countries, India is a middle income country, more than 80 lakh deaths in a year happen because of poor quality of health system. Health providers do less than 50% of the recommended evidence-based actions. At least 1/3 of the patients face disrespectful care or short consultation times, poor communication, long waiting hours, which are all parameters of quality. Less than 25% of people in low and middle income countries feel that their healthcare system works well. This number is more than 50% in high income countries. So just a comparison of what the community also feels about it. Then some data from WHO and World Bank report shows that the service delivery is suboptimal in terms of quality care in both public and private healthcare, as also evidenced by the previous presentation by Dr. Gyani, with less than 1/3 of the hospitals being either entry level or full NABH. 15% of the overall expenditure in healthcare is because of correctable and preventable complications of healthcare, right? Even in high income countries, 1 in 10 person is harmed while receiving healthcare worldwide, which is 46 million patients harmed every year, and 1.4 million deaths, which is much more than either tuberculosis or HIV and both of them put together, because of harm caused because of healthcare interventions, right? So we need to work on quality, which actually ends up working on all these things. As Dr. Gyani said, it also helps in improving the bottom line by reducing the overall expenses. So, we just heard about what NABH has done, Quality Council of India has done for private healthcare providers and somewhat government providers also. However, let's look at the other side. The public healthcare quality, what is the journey has been. The National Health System Resource Center is the nodal agency which looks after the quality certification and accreditation of the government hospitals. It all started in 2008 after the National Health Mission, now erstwhile NRHM was there. It came out with the public health standards for different categories of hospitals, which guaranteed minimum infrastructure, services, and human resources. In the next 4 years, we came out with the Clinical Establishment Act. Almost 20 states have ratified the act. Some others have their own minimum requirements also. So it shows minimum licensing requirements for different healthcare facilities. Moving on to 2013, the National Quality Assurance Standards were out. They came out with the district level standard, the state, the PHC, CHC, and urban PHC level standards, which talked about introducing quality principles in the public health delivery system. 2014 saw the Swachh Bharat Abhiyan coming up. Taking lead from that, the NHSRC came out with the Kayakalp Awards. We talked about sanitation, infection control, waste management in different healthcare facilities, or we can call it the Clean Hospital Awards. Then came the next level, that is patient satisfaction improvement, right? And now it's an integral part of all awards of Lakshya, NCOS, and Kayakalp. This is an IT-based feedback system which is online and app-based. They can also give a hard copy feedback if they require, if they want to. So this was introduced in 2016, and 2017 actually came out with the maternal child health improvement for quality improvement in intrapartum care, wherein labor room and OT, maternity OT were focused on to improve the basic IMR and MMR levels in the country. 2018 saw the standard treatment guidelines for almost all specialties coming out with clinical pathways, and the National Patient Safety Framework 27 to 25, which talks about what things have to be done to ensure that patient safety goals, the global patient safety goals are adhered to by India. So if we can see that over a period of 10 years, even the public health system, and these are the sort of some examples of how quality improvement is inbuilt, in certain parameters of standardized care within these guidelines. And national health programs, including TB, is included in these guidelines, but they don't cover all the gamut and don't go to the level of quality improvement as we have demonstrated in this project. Looking at the guides and standards for different level, one word stands out. They talk about quality assurance, quality assurance. Main focus is on quality assurance, that this is a minimum standards we need to maintain. Now we need to move towards the next level, that is quality improvement. There are certain areas in all these guidelines which talk about quality improvement, but being an assessor myself, I can look into that. The quality improvement is just on paper. We need to focus and work towards practical quality improvement tools. How we can do it? There are existing linkages with the National Health Mission and the health programs, including TB. Use that infrastructure, manpower, and resources. Leverage on the incentivization to push quality improvement by the National Quality Assurance Standards, NABH, for public health facilities, which have led to improvement in labs, infection control, AICs, and available resources. This course coming into how we can now take from TB, QI course to other programs. This course has shown 50 successful PDSAs with measurable impact while being within the existing healthcare system in a resource-constrained environment using an online methodology, which reduces the time requirement. So we need to use these linkages and move to an already existing quality assurance system, which is there in the public health system, and piggyback on that and move towards the quality improvement system using the PDSA cycle as shown previously and other tools which are already existing. Thank you so much.
Dr. Mohan, fabulous. I really enjoyed your slide with that stepwise manner which you showed the journey, and certainly taking the journey which was before Dr. Gyani talked about the hospital and inpatient, and we mentioned a little bit about outpatient, but then you showed it in the public health area, and how we really need to be going from quality assurance to quality improvement. Thank you so much. And Commodore Rahman, over to you to introduce our next speaker, Dr. Meena.
Thank you. Thank you, Dr. Mohan. Thank you, Dr. Manoj. And we are bang on time for Dr. Meena, our next speaker. There is so much that the slide reads about him. And, I am uncertain where to start and where to stop. And his name was taken along with Dr. Rana's name by Dr. Gyani himself. Dr. Meena is currently the Joint Director, Hospital Networking and Quality Assurance, National Health Authority, famously called, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. So he is amongst many other appointments in quality assurance and in public health that he has done and held in Government of India as well as state. He is dedicated towards providing quality and affordable healthcare services to all and improving the quality of healthcare services in India. Additionally, he has severe prestigious awards and accolades to his name and played key role in Ayushman Bharat scheme. So without wasting any time, Dr. Meena, I invite you, kindly share your views with us and please share your slide.
Yeah, good afternoon, Rahman. First of all, thanks to invite me as a speaker, and I congratulate the wonderful workshop. Just I share my presentations. Just for 1 minute. Just for 1 minute. I think this. Yeah. Are you see this presentation?
Yes, we can see, sir. We can see your presentation.
Just for 1 minute. Before I say the quality, why need quality? It's just a simple video is there.
Take your few seconds, sir. We definitely want to see the video. Yes.
Okay. Are you see the view?
No, I cannot. Yes,
Yes, now we see it.
we can.
Yeah. Then another is just a simple language. If I say you find 1 to 49 sequentially, like first 1, 2, 3, 4, 5, within 20 seconds, that we are unable to find, including 1 also. But if the same thing is in the systemized, each and everything will be found within the 20 minutes rather than in 2 seconds. And that's why the quality is very necessary in the health sectors. Because during the emergency, 1 second is also important for the patient beneficiaries. And that's why each and everything is systemized and standardized manners is required for the qualities. And then what is the quality? I say, what is the quality? When we say the general definition of the quality, like the right work at the right time for the right client by the right provider at the right place with the affordable cost is known as the quality. This is only the general definitions. But when we say for the health specific, like the standard environment include the infrastructure, environment include the instrument equipment, environment include the manpower, environment include the training, but each and everything is available. If behavior is not there, then again a problem. And then the standard treatment as per the protocol and guidelines. And the satisfaction for both provider as well as client is known as quality, particularly in the health sector. But if we say in very simple definition of the quality, जो आपको चाहिए वो दूसरों को दो, that means quality. Because I always say that each and every person know the quality. He is the expert in the quality. The only definition changes when I want the services, I need more quality. But when I give the services, I forget the quality. And that's why I already say that जो आपको चाहिए वो दूसरों को दो, that means quality. Because you are the expert. If you are the patient, what is your expectation? If your expectation is for the quality, then why not we give the quality to other persons? It's just simple questions. If you are the patient, what is your expectation of the quality? The answer is 100%, 99.9. But if only 1% is missing, then you know your heart will beat 32,000 times each every year. Means 0.1% is not acceptable. Then this is the problems. 19,000 baby dropped by the doctor at the birth. 20,000 wrong drug prescription made every year. And as you know, the 500 surgical operations are performed wrongly every week. If we accept 99.9, if God cannot think for quality, the DNA between the chimpanzee and our human beings is only 1% difference. If God cannot think for the quality, then we all are chimpanzee. And this is the importance of the quality. That's why I always say that health need 100% quality. Why health need 100% quality? Because 1% error can cause morbidity and mortality. और एक बार अगर आदमी चला जाता है तो हम वापस नहीं बुला सकते. That's why 100% need health quality. Because एक डेथ से हम वापस नहीं बुला सकते कि हम अपनी गलती सुधार लेंगे और अभी चलो वापस आ जाओ. And I always say that the self-assessment is the best assessment for the improvement. I just ask one question. What is the strength you are itself? What is the weakness of you? The answer is very less. But when I say what is the weakness for others, the list is increased. And that's why I always say the self-assessment is the best assessment for the improvement. Because you know your strength, you know your weakness, you know your opportunity, you know your threats. And that's why I always say that the self-assessment is the best assessment for the improvement. And quality is coming from your heart. It's not coming by the any official letter and other things. Because if you realize that I provide the quality to the patients, if you realize that 1% error can cause morbidity and mortality, if you realize that we cannot take back if any one mortality is there, then we 100% sure that this quality is coming only from the heart. And that's why I always say that जब दो दिल अच्छे मिलते हैं तो पूरी जिंदगी अच्छी चलती है.
I believe
not proper, you can't prevent the infection. If nursing is not proper, you can't cure. If pharmacist is not proper, you can't cure. And that's why quality is always a teamwork. It's never achieved by a single person. It's always a teamwork. And the biggest enemy of the quality is that chalta aaya hai, chalta rahega. This is the attitude where the chalta aaya hai, chalta rahega. You never improve the quality. You will change this attitude. And it's very sweet for speak, but difficult to implement. Why? Because it's never improved without truth. And as Dr. Gyani sir is already saying, that Gujarat is the first state where the quality improvement program is implemented in PSC to medical college level. But we realize that without truth, you never improve the quality. And the improvement of the quality only through the fact finding rather than the fault finding or punishment. The fact finding by the direct observation, by the patient interview, by the doctor's interview, by the staff interview, by the record reviews. Rather than the punishment. I think when I posted as a state quality assurance officer, number of the training program is conducted in the Gujarat. About 25,000 participants already trained in the different NABH assessors, NABL assessors, NABH entry-level assessors, PGQM and HO assessors, and others, the WAS and other infection control practices. So we need quality culture, because without any culture, we can't improve the quality. That's why we need the quality culture. And Ayushman Bharat, if you thinking for the Ayushman Bharat, I think Ayushman Bharat is the one of the largest public health insurance scheme in the world, which have each and everything on the quality parameters. Like in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the number of beneficiaries, if you say the 10.74 crores family is there, about 50 crore beneficiaries in there. Each and everything is online basis is there. There will be no capping in the families. And each and every is the totally caseless and paperless, because any manual intervention reduce the quality. And that's why the Ayushman Bharat is the biggest, largest scheme, but it's each and everything is online without paper, and it's totally paperless schemes. And the portability is also there. The Kashmir beneficiaries take the treatment in the Kerala beneficiaries take the treatment in Delhi. And that is the important things of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. As you know, this scheme which is implemented in all over India, except few states like the West Bengal, Odisha, and Delhi's. Within the short period, the more than 2.5 crores beneficiaries take the benefits from the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. We just spent 3 years, but 2.5 crore is not a small amount. About 28,000 hospital is already empaneled with the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And in the 28,000 hospitals, 50% from the private hospital. That is the beauty of this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And they are coming only because of the payment on time. The rejection rate is the lowest, 1%. The cure rate is the lowest, only 15%. And the payment is totally online basis within the 15 days. So this is the beauty of this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. As we say that most of the states are going for the universal health coverage, and government of India is also going for the universal health coverage. Our Honorable Prime Minister is very keen to cover universal health coverage in futures, because health is need for public. And after this COVID situations, you know, each and every person know that what is the need for the health services. And that's why government of India is keen to universal health coverage in futures. As you say, the journey of the Ayushman Bharat, it started from the September 2018 and till now, over more than 27,000 or 28,000 hospitals is impaneled, more than 2.5 crore beneficiaries take the benefits, and the number of the state is going for the universal health coverage. The process is very transparent. Each and everything is online. Beneficiaries come to the beneficiary, then pre-authorization, approval of the pre-authorizations, then the claim submissions, approve the claim submissions directly online, then the payment and discharge treatment, and each and everything is online. And each and everything is a time bond. And that's why we give that payment within the 15 days. If you say, this is the beauty. One is gender equity. After this implementation of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the female take the more benefit rather than the male. Previously, the problem is the female because of the lack of puberty, because of the money is not there, because of the hospital is private hospital is not reachable. But after this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, because we have the 28,000 hospitals in all over India, so the reachable of the hospital is very easy, affordable. So that is the important. The gender is also improved. As you know, we have the health benefit package. It's continuously improvement. Previously it was the HVP1, then HVP2, then HVP 2.2, and now is continuously improvement according to taking the feedback from the hospitals, from the states and other things. About 1359 package is already there in this Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. Related to the incentives, as you know, the quality is really incentives. In the Ayushman Bharat Jan Arogya Yojana is also give the incentive to the NABH Accredited, NABH entry levels, NABH bronze quality certificates, or the metro cities, or in the Ayushman or teaching hospital, or in the aspirational districts. So we give the incentive to the quality also. You see the approval of the claim within the 10 days is 90%. Treatment to the benefit hospitals within the 15 days it is 98% in the Ayushman Bharat Jan Arogya Yojana. And that's why the private hospital is very satisfied to with the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. This is the anti-fraud framework. We have the anti-fraud framework because if you give the best treatment, you have the strong anti-fraud framework also. So we also have the anti-fraud framework. It's very strong. We also have the artificial intelligence and machine learning process. And in future, we are also thinking for the auto claim adjudications. Rather than the manual interventions, we reduce the manual intervention in each and everything is auto claim adjudications through the quality assurance. And this is the National Digital Health Missions, which is very important in futures, especially like the health ID, preparation of the health ID, digital doctors, health facility registers, personal health records, and each and everything related to the telemedicine, e-pharmacy, each and everything is online and transparent, which is really in future healthcare, a drastic changes in India. I think so. We are also have the bronze, gold, and silver quality certifications. Like the NABH full accredited, go for the gold quality certification, NABH entry level, the silver, and if not accredited, then go for the bronze quality certifications. This is just one video. Who will start this journey? Just I say this video.
आप wind up कर रहे हैं, Dr. Meena?
Yes.
Okay.
उस पर कार का इंतजाम किया है।
This video show that tum chalo to Hindustan chale. You forget the other roles. We always say that this is my role. ऊपर वाला नहीं करता, नीचे वाला नहीं करता, बाजू वाला नहीं करता. What is your role for the improvement? So forget the other roles. Only identify that what is your role for the improvement. But sometimes this is also happen. This is just
What this organization desperately needs is change.
So everybody has put change on the table.
yeah. This
Great.
is also happen.
Thank you.
Sometimes we are doing good job, but the change is another types. So that's why I always say that what is your role for improvement? I always say that each and every person know the quality.
Thank you.
Every person know the quality. Only the difference is the self-assessment. The forget the other roles. Please, what is your role for the improvement? Then 100% quality is improvement. So thank you very much. Thanks a lot for give these opportunities.
Great. Thank you, Dr. Meena. A fabulous set of inspirational videos and thought-provoking things that you've talked about. Teamwork, fact-finding, not doing the name, blame, shame game, creating the culture of quality, all really important points. And then taking us in depth of how you and your organization are implanting these principles in the Ayushman Bharat journey. Certainly delighted to have all of those ideas be part of the quality movement as we move forward. So Commodore Rahman, I would ask you to introduce Dr. Sachdeva, our next speaker. Delighted to have him.
Thank you, Dr. Meena. Thank you, Dr. Manoj. Dr. Meena, आपने हमारा जो PDSA का प्रोसेस है उसको पूरा समराइज कर दिया है. Because PDSA के प्रोसेस में हम यही कहते हैं कि समस्या का समाधान जो है वह हमारे अंदर से आना है.
Exactly.
The solution will not come from the government of India. The solution will not come from financial resources.
Yes.
The solution will not come from extra manpower. Yeah. The solution has to come from within, and that is our PDSA approach. And that is how it is, not by spending any extra money.
Yes.
Our next speaker is Dr. Kuldeep Sachdeva, and I'm very delighted to introduce him because he has the perspective of both the sides. He has been the Deputy Director General of the Central TB Division with the Ministry of Health and Family Welfare for 8 years. And now he is the Director of the Union Southeast Asia Office, giving his guidance and vision to the Union, which also is the implementing partner and the authority for our project, our program under the I Defeat TB. So I'll not waste any time. We are so much eagerly wanting to hear you, Dr. Sachdeva. Please go ahead. Thank you.
Yeah, thank you, Commodore Rahman, and all colleagues present here, Dr. and all distinguished faculty and the friends present here. So what I talk today is, I think, being talked right from the beginning of this session. What I say is more or less of a repetition and also a testimonial to what you are doing. Let's go ahead. Can we go to the next slide? So we talk about the I Defeat project. You have heard of this a number of times today. So overall goal of I Defeat project is to strengthen TB-related institutions in India, focusing on both drug-sensitive TB and drug-resistant TB, and with the ultimate objective to achieve India's vision in the National Strategic Plan and United Nations high-level meeting on TB. They had set up some targets about a few years ago, 2018, and how do we achieve those targets? Next slide, please. Now, I Defeat has various components, and training of program managers executive course for district TB officers is one of the components which we have talked about many times today, and Commodore Rahman just referred to Plan, Do, Study, Act, PDSA. So directly, indirectly, many people have talked about it. So the objectives are to develop a course curriculum for program managers in executive training, train a total of half of the country's DTOs, which is about 350 DTOs, and build capacity of the National TB Elimination Program to run this course. Next, please. And all this has been a felt need, which again has been articulated. While we are, most district TB officers are also either public health professionals or they are chest and respiratory disease specialists, and they have huge technical strengths within them. So what probably the missing piece was on the softer skills and also on the leadership skills, and how do we improve managed program per se, the lack of a management orientation and quality improvement feeling. So specifically the program covers, you also heard about quality improvement, leadership management, team building, and looking at your own data to improve your own self. Next, please. We heard testimonials from few DTOs. I think I was missing in action for some time because I was in the other competing meeting, but I heard one of the DTOs. I suppose few others joined later on. So you heard about how they feel about the program. So most of them feel lucky to join this course. They feel motivated and they feel they have a sense of empowerment when they do their work. So, and they find the tool to be very practical. They are now able to prioritize their tasks. They are able to self-assess, self-analyze what Dr. Meena was saying. So they are able to self-assess after taking this course. And many inspirational talks, and Commodore Rahman leaves no stone unturned to inspire people on taking them forward. So we would also be sharing best practices. We keep on sharing best practices which are actually learned on ground, implemented on ground for a cross learning, and if they can be implemented in another contextual setting. Next, please. So all this is very good, but at the same time, people found the course to be too lengthy. I mean, 6 months, they find it's too difficult to retain that attention span and be very regular on a 6-month curriculum. So the recommendation is to shorten the duration of the course. Maybe you can increase the screen time or the time they devote on each session. Some people, I was also joined in when Dr. Meena started his presentation. He referred to environment. So there are still some environmental or enabling issues which some DTOs express in the forms of infrastructure, HR, so on and so forth. But all said and done, with their strong advocacy, it's possible to sort of some of these issues, because many of them are future leaders and they will be sitting on those positions where they want, which position they want people to do what they want to do. And most of them are applying, have their apprehension that applying in the field may be difficult. But then again, I said, when you share your best practice, you put it in your own context, in another context, and see if they can be replicated. So I think these fears also need to be addressed and allayed. Commodore Rahman, a few tasks for you in the next sessions, where you try to address how do you address your shortages in your environment. How do you address, how do you actually convince your seniors to put in resources where they need them? So the way forward is, I think Manoj initially said, can be replicated in other settings, other resources, other programs, or any other industry per se. I think these are very generic self-motivational tools. They are quite replicable. You can also replicate them in your own life. And you can consider expanding them to the private sector. Now, a third of the notification is not coming from the public sector, it's coming from the private sector. So it's almost now 65-35. So don't leave half of the population which is there in the private sector. Thank you for your attention.
Great, wonderful, Dr. Sachdeva, and thank you for your insight. And truly, you have sort of watched this journey. You were part of our joint monitoring mission with the World Health Organization pre-pandemic 2019. And you saw many of the conversations, and then you have brought this program to fruition over the past 2 years, and your suggestions and ideas are well taken and well placed. So thank you for the insight, and especially the point of the ability for PDSA to do self-reflection. And I think Dr. Meena also talked about this whole idea that if we do self-reflection in a structured manner, that can go a tremendous way. So it is my pleasure to introduce our next speaker, Mr. K. Dinesh. Mr. Dinesh is a close friend and a colleague, and in our journey for quality improvement for over a decade, a long story of how we met and worked together. But more so, he is one of the 7 co-founders of Infosys, a company that we know, and he served as a member of the board from 1981 to 2011. He was also the head of quality information systems and communication design group. So he really took the idea of quality from various sectors in the corporate and brought it to the corporate at Infosys. And most certainly, he has now brought those ideas to healthcare, and he's also on the board of Narayana Hardalai. So with that, I am delighted to invite you, Dinesh, to share your ideas and thoughts with our group.
Thanks, Dr. Manoj, and good evening to all of you. It's my pleasure, happy to be part of this important initiative, knowing the impact it has on the society, which has been challenged in the recent times, particularly in the healthcare sector, as we all know. And of course, the end of the tunnel we are going to reach very soon, thanks to our scientists and science, which has provided quick, well-proven solutions in such difficult times. And to me, the fact that I was listening to the various speakers who were speaking earlier to me, policymakers, people who have been able to drive the initiatives, bring the change that is required. They have a vision for this kind of a program, particularly focusing on TB as a specific area. But seeing all the presentations that were there in the healthcare sector that I saw, there is a lot of things that are happening, all of them in the right direction. And my job here is I am not a doctor at all. I'm a mathematician. By accidentally came into software, founded Infosys with my 5-6 colleagues under the leadership of Mr. Murthy. I just want to share, similar to what you have heard from them, what has been Infosys' journey in its quality, what is the kind of commitment we gave to quality in reaching where it is today that you are seeing. But before that, I just want to say that if you need to do a journey like what you're all thinking in quality related to healthcare, you need to have a strategy, and which is falling in shape as we can see. You need to have a set of tools, and you need to share your ideas and tribulations and implementing where you failed, where you didn't. So DTOs are coming and trying to do that for the TB related sector. And learning from each other is the most powerful way quality is implemented. Quality is not implemented on paper. Quality is implemented only when we share like what you are doing here and learn from each other and make sure that those learnings are incorporated in the next journey. So now my next question to all of us would be, so where do we start? What do we need to do? A similar question was asked in the industrial age. We are now in an intuitive age, as you all know, artificial intelligence and virtual reality. So many new things are being found and being implemented. Today, I don't know whether anyone goes to a bank. They do all their transactions on the mobile. So that is the kind of change you are seeing. So healthcare sector has to adapt to some of those things as we go along. That has happened in the rest of the places. So now, in the industrial age, George Bernard Shaw, a well-known person, a well-accomplished person, was asked this question. If you are given money, men, material, and money, men, material, and money, which one of them would you need to succeed? I'm sure you would have a similar question. Are we getting enough money in healthcare sector to do what is required? Is money the problem? Or do we have enough people to do? So knowing the wise man, the George Bernard Shaw was, his counter question was, which I'm sure you are going to ask, is if there is a three-legged stool, which leg is important for you to balance what is required? Now, if you can't balance and stand, you will go down. So you need to stand well. So for that, which leg is important in a three-legged stool? So to me, the answer is in that three-legged stool. People, process, and technology. All three are equally important. None is less important, none is more important. And which is what this program is bringing to all of you, that leaders have committed to doing a journey in eliminating TB. They have defined a goal that by 2025, they want to eliminate in India at least the TB, which is growing in some proportion, multi-drug resistant and all of that. And you are here to learn. And I'm very happy, that you have focused on that. Leadership has defined a specific goal. Edward Deming, the guru of quality, said this: constancy of purpose is very important. When you say quality, quality is not about a set of tools. Leadership has to commit to what is required. And constancy of purpose is very, very important. Today it can't be one and tomorrow it can't be something else. So we have defined a clear goal that you need to achieve, and that is to eliminate TB by a certain time through a set of process and tools that are there, learning from each other, and you want to do that. And that's what you are all here learning. And when we started the journey in Infosys in 1981, 7 of us put together just 10,000 rupees as the capital. We had no experience of running a company on our own. None of us. My father was a high school headmaster. Murthy's father was again high school headmaster. Nandan's father was a manager in a textile mill. Like that, each one of us came from humble middle class background or working class background. We had no experience of creating a company and running, but we had this dream that we will create the most respected company in the world in 1981, sitting in a small flat, of Murthy. But our principles were very clear that we will do it where we win the trust of the client. Trust of the client is very important. By winning the trust, then we will be able to grow business, and that is how we wanted to do business. So when we defined this simple goal that we'll be the most respected company in the world by building the trust in the customers, employees, investors, and the society at large. Now you have seen how Infosys has grown from 107 people organization to today it is close to 3 lakh people, 300,000 people all over the world. Believe me, in 1981 when we started, India was seen as a snake charmer's country. India was seen as a snake charmer's country. How can these guys develop any software and deliver from India? That was the kind of disbelief that was there. So reason I am saying some of these things is quality is about thinking of the future possibilities, laying the right foundations required for you when the growth has to happen, and building the trust with all the people who are there. Now, believe me, in your program now, in the TB, when we eliminate, when you all decided and you will eliminate, what will happen? The trust the society has in all of you will go up so much, that they will say, oh, we want to listen to these guys and do more required, and you have saved many lives. That is what happens when you accomplish the goal that you needed to do. So how did we do this journey? I talked about quality is one of the key goals we needed to achieve. But similar to what you're all laying now, we had to lay those foundations because in software, there was no path from India that one had defined this is how you would do. There was no path, but we had to find our path. And that path was we used the manufacturing related models that were there, ISO 9000. and say we will implement that quality model for software, adapting to what we needed to solve, bringing the on-time delivery, reliability that was required, bringing down the cost, all of that we had to do by adopting the ISO 9000 with ticket as the certification. Today, fortunately for you, thanks to Girder, Gyani and many others who are there on this call, we're already seeing those models being available. NABH standards are there, NABL standards are there. All of those have been defined earlier, things that were required for you to look at a path that you need to take. No, those are really given, I would say, and we had to traverse through that and create those things for software industry, because India had to prove for rest of the world software can be developed from India as reliably, if not better, from India, so that people will come and say, I want to do more business with India and companies like Infosys. So all of that happened. And let me give you the specific example. ISO 9000, we did that. Did we stop there? No, it is just the beginning. We built a quality culture. We built just the quality culture required for us to do. And when we were implementing it, I believe me, some of the senior people, like in the healthcare also, you will find, you may find doctors and medical professionals may say, oh, what is this quality thing? I know what I have to do. I have to take care of patients. And what is all this extra procedure you are bringing? We had to go through similar things in software, because software guys say, I know how to write the code. I know how to do program management. What is this that you are trying to do? So we had to convince them that these are the things we needed to do, and these are the reasons we needed to do, and set up procedures coming from their best practices and start implementing it. And how did they buy into this? As they saw the benefits of implementing it, customers started looking at differently, respecting us a lot more. Those project managers. At the overall business level, what was only 60% on-time delivery when we did the ISO 9000 journey initially went up to 90% on-time delivery. 90% on-time delivery. Because of which many customers would say, this here is a company, you should give more business to them. Repeat business went up from 65% to 90% of our business. And the profits also, unnecessary costs that we were incurring, all started coming down. Defects started coming down. All of those business benefits, as it started happening, many people bought into it, and many other smaller companies and other people also started following, because this became a standard that you have to implement when you want to open a new customer. So that is what would happen. The ripple effect of quality is not just to the current customer, the entire environment believes that this is the way the future will be. And that's what you are laying the foundations for, by the TB program succeeding and showing this is the way it will be done in an organized manner, disciplined manner, with a set of tools, set of expertise, set of numbers that are there to measure its success. You will be able to make it a standard for rest of the organization, rest of the places in healthcare. So that is what would happen to you. And today, when I look at Infosys, I'm retired from 2011, from the board of Infosys. Except Nandan, all the founders have retired out of Infosys. Nandan had to go back. But when we look at Infosys today, when I look at the kind of foundations we have laid, in the early stage, it is like brushing the teeth. It's like brushing the teeth. Can we all learn brushing the teeth now when we are all adults or when we are getting old? Quality is like that. If you can build those habits when it is required in the right stage, and it has already given the benefits, you have built a quality culture. And that's what you are trying to do. So we didn't stop at SCI CMM. CMM level 4 we reached, CMM level 5 reached. But let me give you a brief comment on SCI level 2, level 3, level 4, level 5, which is what you people need to start looking at. Because level 2 is about repeatable process. If you have done a repeatable process, repeatedly you can do, that is level 2, that is the basic. But 90% of the organizations are at level 1. Nothing defined, chaos, everyone does their own way. Healthcare sector has come from level 1 probably to level 2, repeatable process. Now level 3 is about defined. So the process are clearly defined. This is the way it will be done. How requirements are managed, how estimation is done, how different things are done to arrive at. That is the level 3. And level 4 is about capability being measured. And level 5 is continuously improved. So we were the first company in the world, from India, to reach CMM level 5. CMM level 5. And post that, we have been able to implement that across all locations, on-site, offshore, all of that. The reason I am saying all of this to you is, quality is a journey, as some of your leaders have already said. But building the culture required, belief in that, and the benefits that you can derive out of it is the role of the leadership. Leadership has to take the lead and defining that, so that more people will embrace, more and more people will come into that. And that is what is important for you all. I'm sure you're going to do that going back. But I just want to say, we didn't stop with SEI CMM. We went to the even further level of the business level excellence that was required. We implemented the Ballridge program. That is when I came in contact with Manoj, when he was in US, in Florida, and my quality group, I had asked them, I want to look at how healthcare can benefit out of some of the things that we have done through the EFPO program, MBNKA program, all of that. So around 2000, I came in contact with him, and he came to India and met, our friendship. From there it started. Later on, I joined the Narayana Hridayalaya. So we didn't stop at SEI, CMM or ISO 9000. Our quality journey continued with Six Sigma, EFQM, MBNQA. Each one of these models, I wish I had time to narrate the benefits that we got, but the leadership has to take the lead in doing it. Suffice it to say, leadership defines what is required for the future, and they have to take in defining that. American Army, Rahman, I do hope I have another 2-3 minutes time.
Well, sir, you can take 2 minutes, sir.
Okay. And American Army did this research. What is the role of leadership? What impact it has on that? So they did identify 2 sets of monkeys in Africa and gave 2 groups separately a set of caramel chocolates. And in one group, they showed them how to eat the chocolate properly. And the other group, they randomly gave and left it to them. After 2 months, they came back. After 2 months, they came back and looked at which one of the groups has learned the right way. And in one group, they taught only to one monkey. In the other group, they taught only, they randomly gave and left it. Which group do you think has learned the right way to do? To your surprise, it was the monkey which was taught, one monkey which was randomly taught, but clearly identified which monkey. That is the group where many people had learned how to eat. In the other one, they did not know how to eat. They were all struggling. You know why? But that monkey they had identified to teach was the lead monkey. They were able to teach the lead monkey. So leadership behavior is really imitated by many others. So that is where leadership plays a very important role. Each one of you are a leader. With these few words, I'm very happy that you all come together. You've heard from your many leaders, and I'm happy to share some of the experiences I went through in quality commitment Infosys did to reach where it is. And someday, I'm sure Infosys will be the most globally respected company, in our lifetime. Thank you.
Dinesh, thank you so much for your kind words and insight. You are decades ahead in the corporate world in quality, and learning from your journey is very helpful to us in healthcare. And your insight and personal experiences are really truly beneficial to those of us who are taking this task for quality in healthcare. So with that, Commodore Rahman, would be delighted to have you introduce Dr. Rana, who is with us.
Thank you, Dr. Manoj. Thank you, Mr. Dinesh. You have been a mentor to me as well. Thank you so much. Your words continue to inspire each one of us. And with this, I take this proud privilege to introduce another member in our forum today, whose name has been taken a couple of times before. Dr. Rana is the CEO of Quality and Accreditation Institute, and prior to which he was the director and CEO in charge of NABH, Quality Council of India. He has also served as a board member of International Society for Quality in Healthcare, as also the president of the Asian Society for Quality in Healthcare. Well, all I can say, and he has published numerous papers in international journals, contributed chapters in books, and presented several national and international conferences. His passion for doing things differently is what impresses me the most, because that is how you can evolve quality in our already pre-existing structures. That is what JL Meena tried to show through his advertisements and other things. So without wasting a time, Dr. Rana, I welcome you, and I am my apologies that I am handing over to you 10 minutes late, but please say your piece and share your screen.
Thank you very much, Commodore Rahman. Thank you so much. Wonderful. Thanks to ACE for having me here today among this august gathering of so many experts around. And the topic which I have been given, and taking that 10 minutes is like, putting everything together. It's very, very challenging task. But nonetheless, it's really a pleasure that after, Dr. Gyani has spoken on quality in healthcare journey in India, and then motivational talk of Dr. Meena, and then wonderful insight of Mr. Dinesh, it really has put me in a very difficult situation, and that how should be taken forward. Nonetheless, thank you once again. And the topic which I'm going to speak on next couple of minutes is about quality improvement in India today and the way forward. So as you already heard from Dr. Gyani, and it's really gives a pleasure for me to be part of this forum today, and also significantly contributing towards the journey Dr. Gyani mentioned since its inception way back in 1999, I would say. So I have three questions basically put on together, and I'm not going to much technical details, as a couple of my previous speakers, including Dr. Mohan, has covered up those. But I'm just trying to give an overview of where we are and how we should be moving forward in healthcare quality improvement. So the first question I ask myself and everyone around is, what is the perception of healthcare quality improvement in India? The second question is, how do we know which healthcare facilities engage in quality improvement? We have hundreds of thousands of healthcare facilities in India. So how to find out who is doing what, and if they are doing in what manner? And the third question is, what are the ways of improving quality? So these three questions are really challenging questions, and I just keep pondering on these questions to move forward in having some answers towards it. Most of you by now in last several minutes have heard word accreditation several times. And when you link about quality improvement, and many people understand that accreditation is the quality improvement. But it's not true. It's one of the tools. It's one of the way of improving quality, but it's not the only tool as we talk about. So Dr. Gyani mentioned in his speech about the journey of quality healthcare. And if I just put this slide up for you for quality improvement, which is very common and synonymous to accreditation system in India, is way back in 1999 in NABL, when the accreditation for medical laboratory, I would say the medical laboratory part of healthcare system, started accreditation as per ISO 17025. In fact, at the time it was Guide 25, but in year 2000 it became 17025, where medical laboratories got accreditation. And I'm very happy and delighted and proud to say that I was part of that in NABL in 1999 when this things kicked off, and then ISO 15189 published in 2003, and again I was part of it, bringing 15189 to India for the first time, and then train and run the program in NABL. And then, as Dr. Gyani mentioned, in 2006, NABH was set up. And again, I was really fortunate to join this in February 2006 to part of the founding team to kick off NABH accreditation program for the first time when the board approved it. And then Dr. Mohan Kohli covers it about the third organization which has started healthcare quality improvement and accreditation in India is NHRC under NQAS, set up in 2007, but the first set of public standard for public hospital came in 2012 and then move forward. And the fourth organization, which I'm leading now, is Quality and Accreditation Institute, set up in 2017. So this is really a really great honor that I have been part of first, second, and the last, but the third as well in some capacity, not directly or indirectly. I know the NABH standard got its accreditation in 2008 when we could bring incentivizations to CGHS, MPEN and hospitals, and then NQAS got its co-accreditation for the hospital in 2016. And at that time, I was the chair of its co-accreditation council, so I can say I was related to that, and of course in QI 2017. So the question is that why healthcare facilities, choose for quality improvement or accreditation for that matter? Though again, I'm saying quality improvement is a big umbrella where accreditation is one of the component of it, but there are several other things which can be taken up. So this is driven by three things. One is the mandate, second is future business prospects, and the third is beyond mandate. So quickly on the first, why mandate brings it and why it drives it. It's mandate through financial incentives by insurance provider, for example, CGHS, which started, giving incentive to NABH accredited hospital, even JCI accredited, any organization which is SCO approved with 15% incentives over and above the base rate. And then, of course, PMJY, Ayushman Bharat under National Health Authority incentivize to accredited hospitals. And then mandate from insurance regulator IRDA came in 2016. Then if you are providing cashless treatment, then you should be adopting NABH entry level or higher standards for that matter. So, but mandate yet voluntary. It's not forced that if a hospital choose not to be getting any benefit out of 1, 2, 3, then you need to go for accreditation. So it's remain voluntary. So if you choose to get benefits, it's become mandatory. The second driver is the future business. So there are no the immediate benefits, no current, but it's linked to the future financial implications. It's business mandate to secure funding, make its brand, it's brand building or image building, and maybe the selling the business. And the IPO is going on, and healthcare is not an exception to that. And the third one is the driver is the medical value travel, where hospital would like to engage the patient from overseas, and they want to show it as a business model that they are based on quality. And the third driver is beyond mandates, neither one nor the second one, absolutely voluntary. Okay, and this is where it is a self-regulation and self-driven, where there is no financial incentive, there is no other business propaganda, but it's absolutely what I want to improve upon. And I think this is going to be, in time to come, the most sustainable one. And I'm not going much on that. I will talk about quality management. If you say, we have been talking about quality management for last several decades, and when started 9001 quality management system certification program, and quality improvement is one of the blocks, if you say, in the quality management system, in addition to quality planning and quality control. So when you look about the quality improvement, and there are so many quality improvement projects at the moment I'm come across being initiated by a couple of organizations to set the standards, what you are actually trying to achieve, and then start measuring around that standard and see if you are improving. And if you subsign the improvement, then you say, okay, that's working. And that's where your PDSA cycle brings up things. And then you design your own methodology, and you design your component, and then put your plan, do, study, act model into it, and then evolve around it, and then improve, walk around, and move forward. So dimension of quality improvement, if you look at why do some improvements work in one setting but not in another, as Dr. Pratibha was also talking about, and one of the component was that it may be hold good what you're trying to bring in your organization here, but may not be replicated to another one. Why? Because it's not simple. It's quite complex situation. Do we have a lot of, the methodology available? Yes, there are system exists around the world. There are improvements taken into, the greater heights. There are significant expertise available, and there are access to methods and tools. But despite that, it's not easy. It's difficult to replicate. And why? There was a good publication, The Problem of Context in Quality Improvement. So it's not that what PDSA cycle brings to us, but is that the context as well. What the problem we are looking at to solve? What are the role of practical wisdom in studying and understanding quality improvement activities? Because there are different components when you design a study, and then you try to move around to see if you are able to move forward in a positive directions. So some of the challenges, in quality improvement, which any healthcare facility which is trying to build up a quality improvement projects faces. Do we have sufficient examples for quality improvement? There are good literature available around the world. There are good things couple of organizations started doing in India, but it's not that significant in terms of when we compare with the number of healthcare facilities we have in India. And I appreciate what Dr. Manoj mentioned in his opening remark. He put it that we can improve without spending more money, without putting more time. And I think that's what the concept is, to bring back to each healthcare facility, to bring around that how we can really work in existing resources and so the example for improvement. Do we understanding the basics of improvement? Do we really understand how to measure improvement? Maybe we having some improvement, but do we have some a quantification of it to say it that yes, we are improving or we are not improving? Do we understand the importance of influence of context? And that's what the context bring is, changing from one healthcare facility to another one. Do we have a defined methodology to be used? Do we learn how to scale up? If we are able to successfully, move a project up, which shows improvement, are we able to learn to scale it up and make it available to other organizations? How to facilitate quality of care? So if these are the things which we keep looking at, and if you look at this, do you understand quality improvement? I keep challenging my colleagues in healthcare world that really we do understand quality. So there are three responses. Yes, I do in practice. Yes, I do, but I'm not sure if it works for others. So that's the contextual differences. And third is I'm not sure. So we are looking for the first one to really make a difference in healthcare quality in India. At the moment, we have some of second and many of the third one. So way forward, as I could see, the way forward is a lot to be done, and a lot has been done in last 16, 17 years in healthcare quality since 2006 and way beyond for medical laboratory 1999. We have learned a lot, we have done a lot, but there is a lot to be done because we have masses, we have numbers which need to be taken care of. We really need to analyze accreditation versus quality improvement. I appreciate, and then I realize, because I'm into accreditation for donkeys here, I can say that it's really a wonderful tool. And when you talk about quality improvement, you work in a project mode, right? You take some problem, you start solving it. 3 years, 4 years, 5 years, and then you might lose track. So the beauty of accreditation is that it keeps you motivated over and over and over again, because someone from outside comes and evaluate you regularly. Wherein QI is not there. It's you design, you work, and there is loser track because nobody comes and evaluate you from time to time. So and it's just in project mode. And that's why the accreditation really works well to improve quality. But there are models which can be working better if you have a monitoring and oversight mechanism existing. So need to develop a culture of quality. And I'm really happy to, which comes from Mr. Dinesh, the industry, that we need to develop culture for quality improvement. It's not something, it's not my business. It's not your business. It's everyone's business. Everyone is responsible. So it has to be looked into two contexts. First is the organizational context, means the facility level. Each facility need to understand that we have to culture quality to improve. It's not something which I look at one component and leaving the other one. Everything has to come together. And similarly for the individual, for me, for you, for everyone around. So it has to go hand in hand for both facility as well as individual level. And then we have to look at certain drivers of change. Some of them are already existing for financial incentivization. They are a driver of change. And I'm thinking this is one of the most important driver of change has been in building quality. getting into accreditation because there are finance incentives. Otherwise, it's not that easy for any healthcare facility to adopt. Technical drivers of change, how we can empower people, how can we make things technical know-how available to the healthcare facilities so that they can start thinking about it. Collaboration. I think coming together, support each other, collaborating, I think key to success in quality improvement in healthcare. And the last but not the least, as Dr. Gyani also mentioned, who drives it? Consumer driven, demand from the stakeholders. If my stakeholder, the healthcare facility, started asking, I'm only coming to your hospital because you are implementing quality improvement. If you are accredited, I would come to you. I think that becomes a driver of the most important stakeholder key chain in the whole of Gyani. So that's all what I thought to share with you all on this in 10 minutes. But in brief, just before I say thank you, what we are doing at QI, and we set up as an accreditation body in 27, is to drive quality and patient safety. But again, in last 2 years of pandemic, it's not just patient safety, but it includes staff safety as well, community safety as well. We run accreditation programs, 14 accreditation programs in last 4 years, which we have developed. Some of them are very key and very much related to what we talked about, three-legged stool. And I heard Dr. Manoj mention three-legged stool. I heard about Mr. Dinesh mention three-legged stool. And I try to mention three-legged stool linked with universal health coverage, accessibility, affordability, and quality. That's why my three-legged stool is for universal health coverage. And the program which we develop is keeping that universal health coverage. Telehealth. In last year, how telehealth has grown worldwide. And in India, when the MCI did an MCI, NMC now has made it guidelines for telemedicine practice guidelines. We provide a telehealth accreditation program. We provide a home care accreditation program, very unique. COVID-19, home care management. So there are certain things we are trying to reach: accessibility, affordability, to people to reach telehealth, home care. And then, we provide, programs. And happy that we are part of international community. As my earlier organization, NABH, got ISCO accreditation for standards. We got 2 standards, dialysis and home care healthcare, accredited by ISCO, making us the first accreditation body in India having this significant achievement. And part of International Society for Telehealth, Asia Pacific Accreditation Cooperation. So I think this is the whole ecosystem of a national and international collaboration, which actually drives quality in healthcare. And most importantly, these international arena gives us an opportunity to think, collaborate, and really look at that. What is our problem in my healthcare facility? And that's the contextual differences from one healthcare facility to another healthcare facility, where your PDSA cycle comes in. You define what your problem is, you think what solution you might bring, and you can think of and really move forward. So thank you very much for giving me these wonderful 10 minutes to share what I could share in relation to what exists in quality improvement in India, what we can do in future. Thank you very much.
Great. Dr. Rana, thank you so much for your insightfulness and really the depth of what you covered is, why QI is so critically important, and also the whole idea of aligning. I think that is so important that we sometimes call it pay for performance. You align your financial incentives with your quality incentives. So thanks so much for your contribution. Now I want to ask one of my closest friends, Dr. Dilip Mathai, who's the dean at Apollo Medical School in Hyderabad, where the AAPI meeting is going on. He is also a former professor at CMC Vellore, where I met him. He has done over 220 research papers and books. And in fact, he and I have done a book together on infectious diseases. So Dilip, delighted to have you here and to share some of your quality journey at your hospital and with your institution.
Yeah, thank you, Dr. Manoj, and I listened to all of these wonderful quality lectures, and I've also been rewarded very favorably with all the inputs that several have provided me. I do not wish to take too much time, but I just wish to state that we are also very conscious about quality in medical education, quality in the PG education, etc. But we have no yardstick to measure. The only yardstick to measure is the passing out exam, or the number of people who get a good placement, or the percentage who passes the exam. But what we are talking about now is about the hospital patient care. Now you have looked at patient care in the let's say in the public health field, but we are looking at patient quality at the hospital level, as that is what NABH and all of them monitors our services. But there are certain areas that we have got a number of things, like why is there a delay in surgery, why is there a cancellation of surgery, why is there an hospital associated infection, why there are so many things that we have done, but that's not the purpose of this presentation. We chose a topic that would resemble very closely the problems that are associated with public control of TB, equivalent to control of antimicrobial resistance, which is a very major problem in our country in the intensive care unit. We looked at a respiratory illness such as let's say pneumonias, and tuberculosis is also a respiratory illness. We looked at combination therapies in our hospital for the treatment of pneumonia, where only a single monotherapy or no therapy is required in the treatment of COVID, versus multiple drug therapy in the environment. We looked at a disease like TB, which is a little long duration, 6 months, 9 months, 12 years, and the propensity for development of multi-drug resistance is simply because of poor adherence or the stop and start treatment of the patients. But here we have a situation where in the ICU we have an epicenter, which is the harbinger of many multi-drug resistant organisms. So we wanted to make a quick presentation. I request my colleague, my intensivist who did the study along with us, in how we approached the problem of let's say introducing antimicrobial stewardship in an intensive care unit. Dr. Mahendra, are you on?
Yes, sir. I'm here, sir.
Yeah, no, please proceed. Please proceed and make it short, and then just you have listened to all your presentations, okay? Yes, and then we will take some questions. Thank you. Proceed, Mahendra.
Thank you, sir. So, wonderful, sir.
Dr. Mahendra, do you have the slides you're sharing?
Yes, yes. And this.
Okay, so I'll ask. Great.
Can you see the slides, please?
Yes, we can. Great. Thank you so much.
Thank you for this opportunity. I want to thank Dr. Manoj Jain and Dr. Commodore Rahman for this opportunity. It feels like I'm a minnow among the Jains that I'm listening to. And I would really thank Dr. Dilip Mathai for this opportunity to attend this conference and also speak about it. So as Sir has already introduced, we have done AMSP program in COVID era, when the first wave has come and when we were battling with the COVID. We looked at how antibiotics were used, and then we wanted to see how AMSP, if we bring it in a short span of time, whether we can bring any change in terms of overall antibiotic usage. So as we know, and I think it has been highlighted over the past 1 year, that the COVID era has brought in another threat along with it, that is the antimicrobial resistance because of excessive usage of antibiotics during COVID. So me, along with my colleague, Dr. Gyani and Dr. Dilip Mathai, we have done a small study looking at the changes that we can bring in. So we'll be covering in a kind of a PDSA cycle as how we have assessed and what we have done to improve our overall quality in terms of AMSP. So we have known the number of cases that we went through in COVID-19 during the first wave itself. And then there are studies which showed that at least 70 to 80% of COVID patients, whether they're mild or moderate, received antibiotics. And it went to up to 100% in ICU setting. And that came up from a preconceived notion that patients admitted into ICU with a pneumonia, community-acquired pneumonia, require antibiotics. Same thing goes with if they're admitted to ward, they require antibiotic coverage. So since COVID being a viral disease, that notion seems to be false. So we wanted to educate the prescribers in our setting, in our hospital, to see and bring in change. So This was a study that was conducted and published in 2020, which showed that the worry that most physicians have that COVID comes with a co-infection or a secondary infection, and that justifies the use of antibiotics. And this shows that the co-infection is hardly 3.5%, and secondary infection risk is also 14 or 15%. But if you look at the antibiotic prescribed, it's somewhere around 72%. You see the gap in understanding where it is required and what to prescribe. So our plan was to develop an AMSP in a hospital to look at how an intervention to educate the prescribers will bring in change over the how they use the antibiotics. So our intervention included a focus group discussion. It was planned over 2 phases. The phase 1 was to collect the baseline data of our antibiotic usage, the number of de-escalations, the mortality, and then we produced an intervention that was, we introduced focus group discussion over a span of 3 days with our colleagues who were the prescribers who were attending the COVID patients. And then we tried doing a weekly feedback to prescribers, trying to tell them how they're using the antibiotics now. So we felt that that would be a better way to reinforce the AMSP rather than a single intervention and stopping. So this was a quasi-experimental study. We divided our population into mild illness and moderate illness, and based on the Ministry of Health and Family Welfare guidelines, we have divided the cases, and then we formed an infection control team, which composed of microbiologists, infectious disease physician, and infection control nurses, and then. We, in the first phase, like I said, we have collected numerous variables, including the severity of the disease, the duration of antibiotics use, and the route of administration, whether there were any de-escalations, and how they choose their antibiotics, whether there were high leukocyte counts, whether the culture reports were seen and changed or something. So that was the first phase, and that lasted for around 3 months. Then we took a 3-day intervention, introduced a 3-day intervention, wherein we talked to, as I already mentioned, we spoke to the prescribers. We took a 2-hour session each day, telling them what are the antibiotics that can be given or when they can choose and how they can choose. And then we started collecting the data over the next 3 months, including same data that like in the first phase, but we were sending back some feedback to the prescribers, telling them how they have been using those antibiotics, how they are bringing in the changes, whether they are doing it more, whether they have changed their prescription. We never restricted them per se, saying that you have done something wrong. We are just reinforcing what they're doing. And we measure the primary outcomes as a WHO standard, that is the days of therapy of antibiotic per 1,000 patient days. And then we'll also measure the secondary outcomes, that is the number of percentage of de-escalations, number of patients in whom the bacterial cultures were sent, and what was the length of stay with the change, with the mortality change by using lesser antibiotics. And we, after that was done, we have analyzed the results, and the baseline characters remaining same in both the groups, even though the number of patients in the second phase were significantly lesser because of the waning effect of the first wave of COVID. But overall, the distribution of patients in the mild and moderate category more or less remained the same. And what we saw was the DOT per 1,000 patient days have reduced from 589 to 523 in mild and 843 to 585 in moderate and severe. This was very significant. And if you can see, when the DOT per 1,000 patient days over different antibiotic classes, you can see that the beta lactams were where we could produce significant change, significant reduction in the usage, along with cephalosporins. The macrolides still remained as a choice of many prescribers in mild cases, which later on got changed. And in the most significant change I've seen in the ICU, in the critical care setting, where we have seen a significant decrease in use of macrolides and BL and BLI. Although we have seen some increase in carbapenems and cephalosporin usage, but later on analysis, we found these were culture-directed therapies, and for sometimes non-respiratory illnesses or when the patient was in critically ill or in shock. You can see the tetracycline usage has almost negligible in the second phase. This was a Pew Charitable Trust study in the first 6 months of COVID wave in US, and they have also seen something similar. They have seen the broad spectrum antibiotic usage in approximately 15% of the patients, whether they were in hospital, whether in the ward or in the ICU. And in that, many of them had increases of producing Clostridium difficile infections. So on our analysis, we have found the significant reduction in antibiotic usage, and we found out azithromycin was the most commonly prescribed antibiotic in the mild category, being and ceftriaxone sulbactam being the one which have been used excessively in moderate to severe category. Like I said, the use of carbapenems and cephalosporins, which have increased, wherefore using for secondary bacterial infections, which have cultural positive proven, or other infections like urinary tract infections or soft tissue infections. And also the secondary outcomes, we have seen the de-escalations in both mild and moderate categories, which was very significant. And also the number of bacterial cultures that were sent also increased in the ICU setting. They started using more culture-directed therapies. And with all these changes, there was no change in length of hospital stay, nor there was any change in the mortality. And this was what we found out. And then post our trial, we got the principal and recovery trial reports. And then those also showed that there was no point in using azithromycin. There was no change in the mortality of the patients. And so after our study, after the study was done and after we seeing the results, we have implemented our AMSP as a standard of care for all further COVID admissions from January 2021. And as you know, the second wave hit us in March 2021. And what we did was we just observed how the prescribers would continue with their antibiotic prescriptions without any intervention from our side. And in April 2021, we have done a sample audit of a few number of cases, 45 in mild and 55 in ICU. And we have seen further decrease in the days of therapy of antibiotics. This actually suggested there was a behavior change in the prescribers by a weekly feedback method that we have used. So at the end of this short presentation, I want to also show the graph that we have seen the reduction in the antibiotic usage in moderate and severe infections. So just want to summarize a few things. So we have used the focus group discussion and the feedback audit as an AMSP intervention. And then we have used weekly feedback for the prescribers rather than a single bullet intervention. And then we have found out from the analysis that we have used macrolides and beta-lactams as the most.
Thank you.
Yes,
thank you, Dr. Mahendra. Very nice presentation. The reason why we chose this, I know that in the TB program, the problem is not with the prescribers, but it is predominantly with the people who take the medicine. But who are the future prescribers? The future prescribers are people who are being treated who are being trained in the mainstream education, MBBS and MD. So what is happening? What is happening is primarily, as you said, change in behavior. Education brings about change in behavior. Nothing else works. Second one is you have to give them feedback. Listen, Dilip, you did very well. You made, but yet you did this. So it's only motivation via feedback and education. Thank you very much for your presentation, and Dr. Manoj and team, please take over.
Thank Dilip, thank you, and Dr. Mahendra, thank you so much. What you have shown here is the robustness of the PDSA cycle and its ability to change individual behavior. I think that is so critically important to know that this PDSA strategy, quality improvement strategy, not just works in a TB setting, not just in a hospital setting, but in these various, even those critically ill ICU settings and so forth. Well, it's my great pleasure to introduce our speaker, who is from Boston University, Dr. Nidhi Lal. She's a professor in family practice at Boston University, a close friend. She's in fact in India right now. She was going to be in Hyderabad for the meeting. She's an MBBS from MGIMS, Wardha, and she has pursued other work, including MPH from Boston University as well. She has also worked tremendously in India on multiple field projects and rural projects. But one of her passions is her work in narrative medicine. So we will have thoughts from her Dr. Nidhi Lal, and then Dr. Salil and I will summarize.
Thank you, Dr. Manoj.
Yes.
If you allow me, I would like to converse with Dr. Nidhi. And Dr. Salil, if you can hear me, what we will do is in next 2-3 minutes, we will get our 3 DTOs also on the forum. And we have essentially reached the end of the session. And now we are summarizing and we are taking views of all our participants, audience, and facilitators. Dr. Nidhi happens to be a facilitator and a faculty also for us. And what she does most wonderfully is something called narrative medicine, something which I came across through her and found it deeply interesting. So first of all, my first question to Dr. Nidhi is, what is this narrative medicine? And at the same time, Dr. Salil, if you can show yourself, and the 3 DTOs who are waiting in line, show yourself. We will, close this session in an open house kind of a discussion thing, which starts now. Yes, Dr. Nidhi.
Thank you, Manoj, for the introduction, and thanks, Commodore Rahman. So narrative medicine is really learning our lessons through our patient stories. So we have learned about quality, we have learned about patient care, and we have learned about how we have trained our DTOs. How do we translate these lessons that we have learned and learn from each other? That is by sharing our stories. We talk about learning from each other. Several speakers today gave examples of how they have turned lessons learned into practices. And so using this form of teaching has been shown to be very, very effective. And the way I started initially was I started teaching a healer's art course to medical students. And medical students really are great learners. And we realized if we can translate this, so when we teach the CETI course to the DTOs, how do we reinforce those lessons? And hence we created this newsletter to create community, to continue to reinforce lessons, and to move on to principles of such a positive deviance or supportive supervision, etc.
So I'll hold you there. And while I'll share with all our audience present here that, our organization publishes a newsletter wherein we acknowledge these simple efforts and, the efforts which have made great changes in the TB program of our DTOs and their team members. Because we realized over the course, hearing from Dr. Nidhi, and when we were personally, interacting with our DTOs, that majority of the complex problems have very simple and effective and implementable, feasible solutions. So we picked up these stories and we started publishing a newsletter. So Dr. Nidhi, if I am to ask you, you spoke about a word called positive deviance, which affected me as well. Is there anything which strikes you, something, which immediately triggered your memory about positive deviance that you learned in this program?
So, thank you for asking me this, Rahman. In my medical education and in my practice, I had not heard about positive deviance. It's only through the managerial concepts that have been shared through this course, and participating as faculty, I also became a student and I learned about these concepts, and I found them extremely fascinating because, when we talk about hand washing techniques, we never, that was a positive deviance example and real life, and it really connected so clearly. But I was like, I never heard of this before, and I've been doing it every day. So that was very interesting for me.
So I think Dr. Manoj was itching to just add on something I could make out from his body language. But before that, Dr. Manoj, I would just like to amplify positive deviance is something which a participant does, living in the same environment, facing the same challenges, facing the same problems, yet he does something different from within his own resources that changes the direction and the course of an organization, of a policy, of a process, or of a thought. And we saw so many positive deviance examples from within our country, from within our DTOs. Yes, Dr. Manoj.
Yeah, absolutely. So here's a concept, positive deviance, where we all have the same set of resources, yet someone else is able to do better or more and be more successful. And the question is, why don't we study how they did it? And they're willing to share it. And that's how we come to that conversation. And I will say this with Dr. Nidhi, that what Dr. Nidhi does is bring many of these topics and issues to the forefront of the floor by having a conversation by narrative. She also has a wonderful podcast and would really encourage people to listen to it, and it's very telling. So wonderful, Dr. Nidhi, for you to be sharing so many stories and then putting it in a tool such as the Quality Matters newsletter.
Thank you.
And with this, as we come to the culmination, we started with two wonderful ladies, Dr. Anupama and Dr. Rebecca, and we bracketed our entire session with Dr. Nidhi at the tail end. Thank you, Dr. Nidhi. And now all it remains for me is to bring in Dr. Salil Bhargav into the game as we wind up with him and three of our wonderful DTOs who will join in. Dr. Salil Bhargav is also the co-founder of CETI, and between Dr. Manoj and Dr. Salil, the entire game is being played, the vision is being played out. And Dr. Bhargav is a pulmonologist, medical teacher, administrator, writer, and an expert in quality improvement in healthcare. He has done his graduation and post-graduation from MG Memorial Medical College in Indore, a 125-year-old medical school. So I welcome you, Dr. Bhargav. As also, I take this opportunity to welcome Dr. R.B. Sutharia, Chief District Health Officer and DTO Devbhoomi Dwarka, a wonderful player in our journey of PDSA. He has 20 years of experience in working in government sector, as also in quality assurance. And I also welcome Dr. Fulmali, who's DTO Anand. Dr. Fulmali, आपने हमें बहुत सिखाया है, आपसे हमने बहुत inspiration ली है. I welcome you. Dr. Syed had to leave. There was a COVID call at the hospital. He has just left. So, may I request Dr. Salil to engage these three DTOs, take their feedback, what they learned from the program, where do they think we can go from here, and how we can upscale it and put it into the entire public health. Go ahead, sir, please.
Thank you. Thank you, Commodore Rahman. Although we have reached to the last part of our program, the wonderful meeting today, we have heard all our expert speakers, but we have some friends who have been in this field of quality, and they are the practical, the persons who have been doing it practically. So, मैं आप सब दोस्तों, Dr. Sutaria, Dr. Fulmali,
Dr. Chandresh Vyas is also here. I'm sorry, I forgot to mention Dr. Chandresh. Yes, he's also here.
Dr. Chandresh. So, I welcome you all. Or I would like to inform you, the audience who are with us today, that these 4 DTOs are with us in the this program, executive course, and they have done, they have shared with us a lot of interesting and important programs and the things, activities which we have done, and we would like to listen from them. And should I start from Dr. R.R. Fulmali? Dr. Fulmali?
Yes, sir.
तो हम आपसे सुनना चाहेंगे कि आपके एंड पे आपने इस प्रोग्राम में क्या सीखा और आप क्या हम सबको बताना चाहते हैं आपके प्रैक्टिकल एक्सपीरियंसेस.
First of all, I would like to thank CETI for inviting us on this platform, sir. And thank you very much for our introduction, sir. We have learned so many things, even though we are very senior persons, but during these 6 months, we have learned a lot of things. Leadership, management, data analysis, SWOT analysis, and all the PDSA cycles. And PDSA cycle has helped us in achieving our target, whatever we have aimed, whatever we were lacking in our district. So we used to do the PDSA on NPY, Nikshay Poshan Yojana, which is to be given to 500 rupees per patient every month, for 6 months or till the treatment lasts. So we were very lacking in the NPY, and our achievement was just below 50%. And at that time we bring the PDSA in our gear up, And so we make the team of 7 members, and then we do the process measures, outcome measures, we do the process map, we see that the every step what we are lacking, and we plan to do the things in that way. And ultimately our plan was very successful, and the initial we were on 757 in July 2021, and in October we had released up to 2,906 patients. We paid the Nikshay beneficiary, and that is our achievement in that field. So the beneficiary was NPY, and they were given in DBT method, so directly benefit transfer to them in their bank account. So it was our achievement, and the because of the team we could achieve that. And PDSA cycle we want to adopt in other indicators also, sir, like successful outcome and notification in private sectors. And so we want to continue this PDSA cycle to use in other indicators also. Thank you very much, Seti, for doing for carving us. Means we were stones, and you carve us like जैसे वो शिल्पकार बनाता है सर, उस तरह से आपने हमको शेपिंग किया है सर. Thank you.
Thank you, Dr. Kamali. Thank you for your words. Manoj, do you have any comments? Commodore Rahman?
No, I think that's excellent. This is the work on the ground. Continue.
और हम समय से वाइंड अप करेंगे.
Right. So we move to next DTO or a participant, Dr. R.B. Sotaria.
Good evening, faculties, presenters, DTOs, and especially our QICs. First of all, I would like to thank for inviting me to share my feedback. So the journey of executive course with the CETI is outstanding. They have taught us many topics. In few topics we have improved and we learned many new topics during this course. If someone asks me to choose 3 topics from whole course, so I would like to choose first topic is teamwork. So teamwork is a key thing in which you can select, you can make a good team, and it will change your whole task or whole goal or everything, and you will be able to improve your task. Like in Savarkata, we have a good team, and we achieved 12 certification, national NCOS certification in PSC. Same in Panchmal district, I worked for only 3 months. And there with teamwork, we achieved 7 NCOS certification. So teamwork is a good subject which was taught to us. Second is motivation. Motivation is a bigger topic. So we can appreciate our staff with words, or by giving them certificates, or by giving them chocolates, or some small things during training course or during review meetings. So review meeting cannot be only review or analyzing or something. That can be a promoting or appreciating a platform for our staff. So it impacts a lot on future work also. And third thing I would like to choose is supportive supervision. Supportive supervision is a key tool to improve in work, because I have worked 20 years. So I have seen era of Inspector Raj also. And now in this era, we are talking about supportive supervision. And now I believe that supportive supervision is a key tool to improve our programs. And we have experienced, I have also experienced as a CDHO in Devbhoomi Dwarka. Now I am coming to PDSA. PDSA is a great tool. I have heard this tool in our NQuas and Kayakalp processes, but it was just a run through word for us. But when I joined this CETI course and PDSA, I came to know this PDSA tool. The PDSA tool provided by CETI is well structured and scientifically proved. And the 2 key things which I learned in with this PDSA cycle is, if you use this PDSA cycle smartly with setting a smart objectives, we can make a bigger change. And second thing we learn is don't be overambitious for any of your goal. Set your target and go for incremental change in your any type of indicators. Like we had performed in our this Arogya Setu application download. So we set a target of 50%. But over a period, we learned that it is a good tool and we performed up to 100%. So in Devbhoomi Dwarka, in Gujarat state, Devbhoomi Dwarka was first to achieve 100% Arogya Setu application downloaded in this patient's mobile application. So thank you, CETI, for giving me opportunity to learn this executive course. Thank you very much.
Thank you, Dr. Raj. Raj, my question to you, can we extend it to other health programs also, what we have done?
Of course, sir. Of course, I have used this PDSA cycle in this PMJ card enrollment also, because we have in survey we have 96,000 patient citizens enrolled, but we were able to give cards to only 23,000. So then I started to plan under PDSA, and we are able to give in 20 days almost 13,000 cards to in 20 days. So PDSA cycle can be used in many ways. Like now we are planning to implement in this in latching also. Breastfeeding is a zero cost intervention to improve the nutrition. So we are planning to use this PDSA cycle in latching process also.
Great. So thank you, Dr. Raj.
Thank you.
And yeah. So we move to the next dynamic member of our team, Dr. Chandresh Vyas. Dr. Chandresh, over to you, please.
Good evening, sir. This is a very fruitful and learning sessions for me. And I'm very happy to hear a word from the legendary world. Especially, I had in real sense, what you need is give to the others. It's in real sense is the epitome of the quality itself. Sir, I'm eagerly passionate for doing the things differently. So we work and focus and for beyond the mandate, because that is only the quality is there. It's my pleasure to be a part of this session. Thank you. Thank you, sir.
Thank you very much. I think, is Dr. GM Saeed is also there? Or yes?
No, sir, he's not there, sir. We'll now close. May I request Dr. Manoj and Dr. Salil for their closing remarks, and just give me a minute in the end to give my vote of thanks. I'll take everybody's name, and please share your closing remarks, sir.
So in fact, we have enjoyed for the whole day the experts in their fields, the words of wisdom. And we started from Manoj, and we heard what we have been doing at CETI and what we have been done with TB control program. Over to you, Manoj.
Absolutely. So as we conclude, it has been a remarkable 3 hours plus a few minutes. And, there are certain inflections in life which take you to a higher stage of understanding. And in my journey for quality improvement in India, being with this group, I have realized and I am convinced that we have taken that major leap in our understanding together, beginning with the broader vision and mission, bringing it to and sharing the lessons from corporate India, learning from academic, learning from government, and so forth. So I want to thank everyone. I want you to take the videos from this, which we will be sharing, and share with others. Bring them onto the quality wagon so we can move ahead. With that, I would like to thank and conclude, and Commodore Rahman, to you for the final vote of thanks.
Thank you. Thank you, Dr. Salil. Thank you, Dr. Manoj. And before I give my vote of thanks, I would like to answer 2 queries which came in the question answer session. There was a live view of our session going on YouTube, and we had a lot of members logged in. There is a recording also, which we will be sharing, because some members have asked for the recording of the session, and we will definitely be sharing it. And there is a request which has come for the feedback link also. We will be doing that as well. So these were the few queries. May I request all the panelists and everybody else to switch on your videos. This is a good time to smile, and your photographs will be taken while I give my vote of thanks. And I'll take precisely 2 minutes. We have exceeded by 8 minutes. I'm sorry for that. Dr. Jan, thank you so much for collating everybody together, for all these stakeholders, for your vision, and for being the guiding light and beacon. A lot of thanks to you. Thank you, Dr. Anupama, Dr. Kohli. Our association with AAPI is there on a very strong footing, and there is so much to achieve together. And these professional and personal bondings with AAPI and CETI they hold the root, and we are on very strong foundations. Dr. Rebecca, thank you so much for sharing your views. I'm sure we have seen the strength in coalition and partnerships, and we look forward to going ahead with you, learn from you, and play our bit as we go along. Dr. Chandresh Vyas, thank you so much for bringing in your PDSA. You showed us how it was making a difference. And my thanks to Dr. Syed also. He was not here, but he would have shared his views. Dr. Fulmali, Dr. Sutaria. Dr. Ruben, thank you so much for giving us the USAID perspective. We are running the program for you, and thanks for giving us the opportunity, because I Defeat TB project will be very close to our heart, because that was the first step we took towards quality in showcasing to the entire health industry that quality has a role to play, and that is where the future belongs. Dr. Mohan Kohli, thank you so much for enlightening us with your views on transformation in public health. Dr. Kuldeep Sachdeva and Dr. Meena for highlighting. Dr. Meena, thank you so much for your very simple anecdotes. And you made the problem and the challenge appear so simple and so subtle. And your solutions also were so simple and practical and pragmatic. And I'm very sorry to all you gentlemen collectively for not being able to give you enough time. I could have spent the entire night hearing you on and on. Thank you, Dr. Kuldeep Sachdeva. You brought in the aspect from both the sides, and your words are very, very encouraging for us. I have noticed the two observations that you made. I have written down them in bold, and I'll see them first thing in the morning. Each day I get up till the time they're resolved, and that's my affirmation. Thank you, Dr. Mathai, for showcasing, and Dr. Mahinder for telling us that excess of everything is bad, and what we should not do. While we are always talking what we should do, what we should not do is as much important. In Forge, we talk of a white demo, and we talk of a black demo, what we should not do. Change in behavior. Thank you so much for putting it so subtly, very nicely to us. Dr. Nidhi, thank you for your narrative stories. And in medicine, you bring so much of grace and color to our program. We're very thankful to you, and thank you for our newsletters. You taking it, the stories to the entire country, across the globe as well. Dr. Salil Bhargav, thank you so much for being there. I know you had to leave the meeting in between. You had to attend to the COVID patients. There was some emergency which came in, but you were back and nobody realized it. But it's my duty to showcase to everybody that how much committed everybody is. Dr. Rana, thank you so much for your perspective. You heard the praise which has come for you in the chat box as well. Challenges in working towards quality improvement. Thank you for showcasing and taking our attention in that direction. My heart goes out to say thanks to the entire staff who has been up and about for the past 3 days. The IT section who has been working towards it till the last moment. We had challenges to face, but we have won over everything. And of course, to the faculty who have put forth everything to you together. Dr. Pratibha Kohli, thank you so much for showcasing the PDSA to us. And the ePDSA, you make it so simple and nice. If I have forgotten somebody's name, my QICs, you are the ones who keep me always taught. Tell me now. Otherwise, the blame will shift squarely and totally upon you. My thanks to Akshita and all my QICs. Akshita, I take specifically because she's not well. She is terribly down with fever and cold for the past 2 days. And to Krati, she's been with us. She was involved with the program. And of course, all my dear QICs, you are my team on which we stand so firmly. And you are our connection to the DTOs. With this, I take this opportunity and permission of all of you to close this program. We did extend by 13 odd minutes. Do partners for that. And Dr. Manoj, any last
Thank you
words?
very much. Namaste. Have a wonderful, wonderful day, week, and Happy New Year. A bit belated, but again, we will do this again. We have a great forum and conversation. And thank you, AAPI, CETI, as well as Emory. Goodbye and take care.
Thank you so much. And before we close the session, Edwin, before we close the session, please scroll down the chat and take screen grabs.
Yeah, absolutely.
Dr. Meena,
Take
please
care,
go ahead.
everyone. Bye-bye.
Bye-bye. Thank you very much.
Thank you
Thanks
so
to
much.
all organizers for this wonderful workshop. And I also thanks to my Gujarat team, which is see long time back. I really appreciate